I just want to start. My name is Hoyne. I'm a consultant psychiatrist, and I'm pleased that we have our second day of the Congress of the Global Psychiatric Association. And without further ado, I would refer to the chairman, which is Professor Sujita Kar. And I don't know if you want to give a quick introduction, and then we just start with the introduction of the first talk.
So, good evening, friends. Good evening from India. Welcome back again for the second day of the conference with online conference of Global Psychiatric Association. Today we'll be having consecutive several interesting sessions. We'll start with the session of Dr. Rishab Gupta, and the session will be chaired by Dr. Vikas Menon. So I'll request Dr. Vikas Menon to introduce the speaker and the topic, and over to you, Dr. Vikas.
Yeah, good evening, good morning, wherever you are. I hope I'm audible to everybody.
Yeah.
Yeah. So, welcome to day 2 of the event. I'm sure day 1 was very good, and day 2 promises to be even better. So, we kick off proceedings with Dr. Rishab today. He is an associate psychiatrist in Brigham and Women's Faulkner Hospital and instructor in psychiatry in the Harvard Medical School. And he predominantly works in the areas that are at the interface of psychiatry and neurology medicine, and also schizophrenia, bipolar disorder, and particularly in psychopharmacology. He has published several peer-reviewed papers on unusual clinical presentations of psychiatric disorders and unusual adverse effects of psychotropic drugs. So, unusual presentations, and if definitely we are in for a very exciting session on ketamine and esketamine in psychiatric disorders. So something that I'm also keenly looking forward to. So without much ado, over to you, Dr. Rishab.
Thank you so much for your kind introduction, Dr. Menon. It's an absolute pleasure to be here this evening, although it's very early morning for me here in Boston. So I want to talk about ketamine and esketamine.
Can I just say, do you want to share some slides?
I did, actually. You're
Yeah.
not able to.
Dr. Rayner, we are able to view Dr. Rishab's slides.
You are. Okay, that's great.
It might be some issue at your end. Okay.
Okay, that's
Please,
my problem. Okay.
Please go ahead, Dr. Rishab.
So these two drugs, basically, they have kind of revolutionized the treatment of treatment-resistant depression in modern psychiatry, and they have kind of ushered in, the new age of psychedelic drugs as well. Before that, as you all may know, we were mainly using antidepressants, mostly serotonergic, working through serotonergic mechanisms and norepinephrine receptor intake, transporter uptake inhibitors, and those drugs had very, limited effectiveness. Even though they are quite safe, but they are not very effective, especially when there is treatment resistance, which tends to occur in the context of people having comorbid medical illnesses, metabolic syndrome, or neurologic diseases, substance use disorders, etc. And these drugs have enormous potential in terms of helping those patients who don't benefit from conventional antidepressants. So in this schematic, as you may notice, this is a molecule of esketamine, and then this is glutamate receptor, and how it works on the glutamate receptor and can reduce depression. And as you can see in this another slide, that there has been an exponential increase in the literature, in the research papers on esketamine in the last 6 years. This is, I just use a keyword esketamine in PubMed, and you can see there are almost 1,800 results, and mostly in the last 6 years. So this buzz that has been created by esketamine and ketamine in the clinical and research communities in psychiatry has also been felt in the media. A lot of celebrities in the US, from TV, from sports, from business, they have actively come out in support of ketamine and esketamine, like how it has helped them in their lives when they were very depressed. Some of these prominent people are Ryan Reynolds and Elon Musk and Michael Phelps, the glorious Olympian, but it also has had its negative stories as well. As you may have noticed in the news a few years ago, a very famous actor Matthew Perry, he died due to ketamine overdose, which was prescribed to him by his psychiatrist for treating depression. A lot of clinics have mushroomed up in the US, which unfortunately are not very well regulated in the last few years. It is proposed that it is actually estimated that ketamine clinic economy is almost a $3 billion economy at this moment. And there are almost 3,000 plus ketamine clinics which have come up in the US in the last few years. So whether it is a miracle drug or is it a double-edged sword, we are going to discuss that in detail today. So first, let's talk about the history of ketamine and esketamine and how we got where we are today. So ketamine actually is a very well-known anesthetic agent which was repurposed to use for treating major depression and also is being explored for other psychiatric disorders. And esketamine is basically its S enantiomer, which is the so every basically molecule in the nature, which is chiral molecule, has two mirror images. Which can have different biological properties. So esketamine is the left-sided image of in the ketamine mixture, and it was first synthesized in 1962 because phencyclidine, which was used as an anesthetic at that time, had very bad side effects. A lot of agitation and aggression used to happen with phencyclidine in the ORs. And then quickly it became approved by US FDA as an IV anesthetic agent in 1970, and then very soon people noticed that it could work as an antidepressant too, although the research on its antidepressant properties was delayed by many decades. WHO also included it in its essential medicines list in 1985 because it's so valuable in the emergency rooms and in the in the ORs. And then in 2000 again, it was found that the sub-anesthetic doses, low doses of ketamine, can have rapid antidepressant effects in people with severe depression. And then finally, although it for many decades it was being used off-label to treat pain, only this year in August, US FDA finally gave its approval to ketamine for surgical pain management, and it can treat depressive symptoms within hours in some patients. And then for esketamine, the first trials kind of began in 2010 in people with treatment-resistant depression. It also works rapidly within hours to days. And then finally in March of 2019, so 6 years ago, US FDA approved it as an intranasal preparation along with an oral antidepressant. That was a requirement in adults with treatment-resistant depression. And then European agency also followed the suit. And then a year later, it was approved, in people with depression who are also acutely suicidal. And then in this year, it was approved as a monotherapy. So you don't need to add another antidepressant to start esketamine in somebody in the US. And then treatment-resistant depression was defined as people with depression who have failed 2 adequate antidepressant trials. And then there are many other, routes by which ketamine can be used. A lot besides IV route, it can be used as intramuscular, nasal, oral, rectal, subcutaneous, sublingual, and different routes require different doses because there are because of the differences in their metabolism through different routes. Ketamine has a very high first pass metabolism. As a result, its oral absorption is very limited. So it's only up to 29% max compared to IV. And it is extensively metabolized by the liver by the CYP450 enzymes, which, as you may know, are also implicated in metabolism of many other psychotropic drugs, including antidepressants, SSRIs, TCAs, antipsychotics. Therefore, when you're using esketamine or ketamine, you must be careful with drug-drug interactions when people are on other medications as well. And there are several active metabolites of ketamine in the body, including norketamine and hydroxynorketamine, which actually is quite potent. And then its elimination half-life is very short in adults. It binds to NMDA receptor. Esketamine binds to NMDA receptor with much higher potency than the R-ketamine and overall the racemic ketamine. And that's why esketamine requires a smaller dose as compared to racemic ketamine for it to work. And the mean bioavailability of esketamine is around 50% with nasal spray administration. Um, and how does it work? As I mentioned, it actually binds to NMDA receptors both in the receptor site and allosterically. It antagonizes the receptor, and it also then leads to AMPA receptor activation, which are other ion channel receptors, glutamate receptors subtype. And then this AMPA receptor activation triggers second messenger pathway, which then leads to neuroplastic changes downstream, which is responsible for rapid sustained antidepressant effects. There is also mixed evidence regarding whether ketamine has an opioid agonist role or not implicated in its antidepressant effect. It does activate mu, kappa, and delta opioid receptors, and it can also work as an analgesic in conjunction with opioid treatment. In fact, it actually works very synergistically because it reverses the opioid-induced respiratory depression. Now, in this schematic, I've highlighted, the mechanism of action of ketamine in detail. It's a very busy slide, so please bear with me. So as you may see, NMDA, the ketamine, it actually binds to the extrasynaptic GABA receptor, GABAergic interneurons, which are inhibitory. It inhibits the GABA neurons, and that as a result, there is increase in the glutamate release in the synapse, which then causes downstream changes, second messenger changes, leading to increase in the upregulation of mTOR complex. So mTOR is basically mammalian, target of rapamycin, and that when that happens, there is upregulation of postsynaptic density 95, and it also basically increases the expression of AMPA receptors on the neuronal synaptic surface, and then that also then secondarily increases the upregulation of the translation of BDNF, which is a neurotrophic factor, and that is believed to lead to antidepressant effects as well. And in addition, ketamine can reduce the firing of lateral habenula neurons, which also confers its antidepressant effect. It can also bind to the mu opioid receptors on the neurons, and then in addition, it can basically increase. It can also exert its effect through the myosin kinase receptor B as well, by promoting the neuronal growth essentially. So that's how it basically works, and this mechanism is very unique compared to other antidepressants that we have in the market, and that as a result it basically shifts the balance between excitatory and inhibitory neurons in the brain towards excitatory. And then in terms of esketamine, its efficacy and its safety has been established in multiple phase 3 trials and meta-analysis, mainly as an adjunct to SSRIs and SNRIs. However, a latest meta-analysis which came out this year, which had 87 studies included, provides a very sobering view actually. According to this meta-analysis, which was published in American Journal of Psychiatry, esketamine effectiveness is actually quite limited, and it starts waning off actually after 4 weeks of use. And this meta-analysis showed that it doesn't really have much of a anti-suicidal effect in the trials. And it also found a very concerning finding that there could be a possible withdrawal effect in patients. So basically, when you stop esketamine or ketamine in these patients, there is like a risk of suicidality in them. In fact, they found 6 patients in this meta-analysis who completed suicide when esketamine was stopped, and none of the patients in the placebo arm, had a completed suicide. So that was very concerning. And so the authors propose that esketamine probably does work like an opioid agonist, and some of the suicidal tendencies that it can trigger are similar to opioid withdrawal related suicidal ideation and behaviors. and overall discomfort that patient experience that we know from substance use disorder literature. Um, and then overall, like in terms of how esketamine is used, so so it is available in the US as a nasal spray, which is covered by insurance companies. It's a 28 milligram esketamine per device, and each device can deliver 2 doses. And the maximum dose that is allowed is 84 milligrams in a patient. And that overall FDA approved schedule for esketamine is basically you can use it twice per week for 4 weeks, and then after that once weekly for 4 weeks, and then subsequently, depending on the response, you can either use it weekly or once every 2 weeks. And I don't know about how ketamine is delivered in India, and I definitely know that esketamine is not available in India and in much of the developing world. But in the US, esketamine is delivered in the clinics and the hospitals where patients will come in with a caregiver because it is not offered when they come alone because they can have like sad adverse effects and they may not be safe in terms of going home alone. And then they have to wait in the hospital for 2 hours after receiving esketamine because of the sedation and other possible, vital sign changes that can happen in them. And then they basically will put on music or, they are placed in a room. There are nurses and doctors who kind of check on them in between. Uh, that's how it is kind of delivered in the US. Um, and then what are its other psychiatric indications besides unipolar depression? So it can be used in bipolar depression. There are some studies on that, not a lot, but few. It is also being explored in anxiety disorder, like on whole spectrum, in PTSD, in obsessive compulsive disorder, in eating disorders, substance use disorders, namely alcohol, cocaine, and uh, opioid use disorder. And some studies have also used it in cannabis use disorder. It is also being used for chronic pain and chronic migraine as well. So multiple, potential indications for which it might get an FDA approval in the near future, and promising findings actually in all of these different disorders. But again, the studies that have been done are actually very small, and there is a lot of variability, especially when it comes to ketamine use in these conditions. Therefore, it is hard to make a strong case for using esketamine or ketamine in these disorders at this current time. And then there was this very well publicized trial that was done and by a clinician researcher at Brigham where I work. It was published in NEJM. It was a very large study, it was a non-inferiority trial in which ketamine was compared with ECT in people who were coming to ECT clinics because their depression was so severe. So they received 3 weeks of ECT thrice a week or ketamine, and there were almost 200 patients in each arm. And the primary outcome was a response to the treatment, which was defined as more than 50% reduction on a patient-rated depression scale. And it was found that 55% of patients in the ketamine arm had response, whereas only 41% patients in the ECT arm had the response. So they were able to basically demonstrate non-inferiority of ketamine to ECT in this landmark study. And it was found that ketamine was actually more tolerable than ECT, and both arms had similar improvement in patient-reported quality of life as well. So therefore, it was proposed that ketamine could be a good alternative to ECT in people who don't want ECT because of the stigma and because of logistical issues. However, there was a Swedish study that was done a year before, which actually found ketamine to be inferior to ECT, but that study was done in inpatient setting. And this study, the one that was done in Brigham, by the Brigham researcher published in NEJM, was done in outpatients. And they kind of defended their findings by saying that ECT typically responds. People typically respond well to ECT when they have depression with psychotic symptoms, and generally it's the elderly geriatric population that responds well to ECT. Whereas in this study, patients were mostly in their 40s, the one that was published in NEJM. So that was kind of one of the highlights of this debate. And then, as you can see in this slide, how ketamine was kind of non-inferior to ECT in this NEJM paper. And the MADRS score also actually reduced over time, not just the patient self-report score, although that was used as a primary outcome. Now, what are other routes of ketamine administration which are being explored in research? So all kinds, actually. People are using oral ketamine because it's very difficult to give IV ketamine to patients. Plus, it's very, very expensive. In US, IV ketamine is not covered by insurance. It is not FDA approved. Therefore, patients have to pay out of pocket, and it can cost up to $900 per infusion. So therefore, people are exploring easier routes, cheaper routes. So tablets are being explored, lozenges are being explored. People are using subcutaneous ketamine so that patients can inject themselves. And then there are intramuscular ketamine, which is cheaper than the IV route for obvious reasons, because you need more expertise in in administering IV ketamine. And all these studies have actually shown very promising findings. But again, these are like small studies. As a result, it's still like one cannot say with great confidence that all these non-IV routes are ready for prime time use in the clinics. Now, what are the adverse effects of these medications? So a lot of them actually, sedation, but these are mostly short term. So they are self-limiting. They kind of go away within a matter of few hours after the use. So sedation, dissociation, which means that patients are are awake, and they can move their eyes, they can understand what is going on around them, but they are not able to respond to the sensory stimuli. That is why the term dissociation is used, and that's why ketamine and esketamine are called dissociative anesthetic agents. These drugs can cause dizziness, vertigo, therefore they can increase the risk of falls. If the patient is not supervised, they can ironically increase anxiety, because patients can feel very uncomfortable with these perceptual changes and cognitive changes. They can cause respiratory depression if used at high dose. They increase blood pressure. When with long-term use, especially with recreational ketamine use, people can develop very painful complication, ulcerative or interstitial cystitis, which is inflammation of the bladder. People can have blood in their urine because of that. Some people can rarely have syncope, which is a false risk. I actually have a patient who developed syncope with ketamine, and then US FDA has ensured that esketamine its use is monitored strictly. So there is a REMS program in which patients have to enroll and clinics have to enroll to limit abuse potential, because the ketamine has abuse liability, and so has esketamine. And as I said, patient must be monitored for 2 hours. There is no antidote in case anybody overdoses on these drugs, so they have to be treated empirically. Luckily, these drugs don't prolong QT interval in patients, so that's a good thing. But patients must not engage in any hazardous activities which require mental alertness on the day when they receive this, which kind of limits their functioning for that day. And now, what are the contraindications? So FDA has mentioned 3 major contraindications. One is aneurysmal vascular disease, even if it is in the thoracic or abdominal aorta. But there is no guidelines on whether one should obtain neuroimaging before starting ketamine or esketamine, which was surprising for me. And then if there is a history of bleed in the brain, or if somebody is hypersensitive to esketamine or ketamine, for obvious reasons. And also, its safety is not established in pregnancy and breastfeeding, so please don't use it in those settings. And also, we don't have safety data available in people who are on dialysis and due to end-stage kidney disease or people with severe liver disease. So please refrain from using it in those settings, or have an open, honest conversation with the patient about that. Now, in case of Indian experience where esketamine is not available, people have begun to use IV ketamine and oral ketamine. And there was a study from JIPMER by Dr. Menon's group. There have been studies from Andhra Pradesh and from a couple other centers which have found ketamine in both oral and IV routes to be effective, quite effective actually, and their rates are actually comparable to the Western data. But the studies are small and not rigorously done methodologically. Um, and this actually also tells us that other countries can kind of follow suit and can use ketamine in their patients, but obviously with caution. Now there is this debate in the literature on which is better. Is esketamine better or is ketamine better? So a meta-analysis was done very recently, I mean actually 4 years ago, in which they had 24 RCTs. No head-to-head trials have been done to this date. I mean, large head-to-head trials have not been done comparing ketamine to esketamine. But in this meta-analysis, they found that ketamine was overall better in terms of response and remission rates and in terms of lower dropout rates compared to esketamine. But if you look at the subgroup analysis, there was no significant difference between ketamine and esketamine in terms of whether the patients were treatment resistant or not, or whether they had major depression or bipolar depression. The other limitations of this meta-analysis were, they only were like very short duration trials, just 4 to 8 weeks. And in this meta-analysis also, ketamine's effectiveness kind of superiority kind of started waning off at 4 weeks interval. And these participants were mostly otherwise, free of comorbidities that we tend to see in the real world. So one must, take these findings with like a pinch of salt, basically. Now, in terms of pediatric use, like in children and adolescents, which is another major group because depression tends to start early in life, esketamine is not FDA approved for children and adolescents in the US for any psychiatric disorder. However, that has not stopped people from using it and trying to and exploring its benefits. And it has actually shown benefit, although these studies are also very small in size. But there is a lot of controversy because these unregulated clinics that have come up in the market are offering ketamine to teens, in an unregulated way, and we don't know, we have no safety data on its long-term effects on teenage brain, like if can that lead to neurotoxicity or cognitive impairment. Nobody really knows about it. Now there is another very interesting development in the field where people are using psychotherapy paired with ketamine or esketamine, which has shown a lot of promise in treating several psychiatric disorders. Again, not FDA approved, but it is being done. But there is also a lot of variation in the studies in terms of the methodology and on what route of ketamine is used, how frequently it is used, what psychotherapy modality is being used. It's all a hodgepodge of different things which is done, but it is showing promising results in various psychiatric disorders. Now, I'm going to conclude my talk by saying that ketamine and esketamine both have brought a novel approach to treat depression, especially treatment-resistant depression. They are safe in short term and have potentially wide indications in psychiatry, but we need to explore their role in special population groups, especially children and those with comorbid neurologic and medical illnesses. And ketamine-assisted psychotherapy is pretty exciting approach as well. But we need studies on long-term safety and efficacy data for both these drugs urgently. And we need head-to-head studies as well. We need to see which routes are better, which dose intervals are better. And we also need to see if there are other related drugs which are better in terms of side effect profile, which could be used and which could be cost effective. So with that, I will conclude my talk, and thank you so much for your attention. And I'm happy to take questions.
Yeah, thank you, Dr. Rishabh. I think that was an excellent overview, and thanks for sticking to time as well. An excellent overview of, you took us through the history of ketamine, the PK and PD of ketamine, the evidence for these conditions in various psychiatric disorders, the adverse effects, and particularly there, we also use ketamine in our center, and I also would like to emphasize that some of the side effects which Dr. Rishabh mentioned are seen only in long-term recreational users. I think that point needs to be highlighted about ulcerative cystitis and all, and the contraindications as well. And of course, the last meta-analysis was very interesting about ketamine versus esketamine because esketamine is very costly even when it is going to be eventually released in India, I think I'm not sure how much people can afford it as compared to ketamine, which is dirt cheap here. So, we actually are using ketamine, and I don't know how much the evidence is compelling enough for us to migrate to esketamine, given the cost and other factors. Anyhow, yeah, I have just one question before I open it to the audience, and it is based on I want to know from your experience that what we have noticed with ketamine is that some people do respond, some others do not.
Right.
There is a clear kind of a dichotomy there, and of course, we are trying to build our own experience with these molecules. But from your experience, have you found any pointers towards what kind of people, what kind of depression responds to ketamine, what kind of depressions don't respond to ketamine? Any leads in that area?
Right. So I would say there is also like a lot of placebo response that we see. A lot of people, with like personality disorder, comorbid, or, people who have like somatization disorders tend to gravitate, or people with substance use disorder history prior, they tend to gravitate more towards, these treatments. And also because they are quite expensive, even in the US, because ketamine is not FDA approved, so not covered by insurance. So people like who are well-to-do are only the ones who are able to kind of receive it. Uh, but overall, I have seen like patients do get better, but the proportions that are mentioned in the studies, we don't see in the real world like that's those same numbers. In fact, in our center, I have seen patients like up to like 30 to 40% patients are responding, but that's just a response. The remission rates are very small, like not more than 20%. And even those are short lasting. So when you stop the drug, most patients tend to relapse very quickly within a matter of 3 to 6 months. So that's why it's a sobering story. Like we were hoping that it will be kind of a game changer. It can kind of get people out of funk. It can help them get out of the acute depression. But then they need something ongoing as well. You can't just rely on ketamine or esketamine to help them deal with their problem, with their psychiatric illness.
Thank you so much, Dr. Rishabh. I think we'll just take a question which is there in the chat window, which is actually allied to what we have been discussing so far, because the participant has asked, even though ketamine affects some of these, neurotropic factors, which could potentially improve neuroplasticity and long-term response, still, why is the effect of ketamine short-lived in most studies? So I think that's a great question to ask, and would like to know your thoughts on that.
Right. It's definitely a wonderful question. And I think this is a question for which I don't have answer. This is something which we need to look into deeply, like why people lose the effectiveness so quickly, like at the end of 4 weeks. And in terms of pharma-sponsored studies as affecting the results, I mean, I don't think most studies that have been done on esketamine are pharma sponsored. They have been actually done because it is covered by insurance. So institutions are able to do these studies independently without any undue influence by pharma companies.
Yeah,
But
but Janssen would definitely like to have their ROIs.
yes, absolutely. Because people may have like other vested interests, like they might have like their own ketamine clinics, right? Or they may have invested uh like money in those, or so in case of, I would say, like in case of ketamine treatments, I would actually take those results with more skepticism as opposed to esketamine results.
Yeah, and you have already answered the other question on ketamine nebulization in
Right.
depression, I
I
suppose.
did not
So,
come across any studies on nebulized route for ketamine. But yeah, I think that will be interesting as well.
Yeah, there are some case reports, in fact. They
Okay.
used nebulized ketamine at a dose of 2 milligram per kg body weight, and they found it to be effective. But it is limited to case report. I don't know whether it is translated into a large clinical studies.
I see.
And
Yeah, I could not find any like big studies, like any
yeah,
trials.
mostly limited to case reports and case series. And I'm not sure whether ketamine to be given directly in an undiluted form for nebulization, or there is some sort of mixing with normal saline or something else to make it diluted form and to give it over 20 minutes. So this is something because ketamine 2 milligram per kg body weight is somewhere close to 2 ml, or in Indian preparation it is 50 ml per 50 mg per ml. So hardly it will correspond to 2 ml. How it can be given for over a period of 20 minutes in an undiluted form, that is again questionable. So it need to be evaluated further.
Right, right.
If you are going for a nasal esketamine, then probably nebulization ketamine might be in a close similar route, might be having effective route.
Right.
route.
But that is just a spray, like that's not like a nebulization.
That is not going to the respiratory tract. That is most of the intranasal.
Right, right. Then I
There's another question in the chat window. You could perhaps take that up, Dr. Rishab. We have a couple of minutes.
Of course. Could that be due to lack of theoretical framework underlying the efficacy? I mean, I don't think we have a very good understanding, honestly, of how esketamine, ketamine work in the brain, right? Like there are many other mechanisms also that have been proposed, which I did not mention, just for the sake of time. Those could be reasons why if it loses its effectiveness. And then the next one is, in which patient would we prefer ketamine as an anesthetic agent in ECT in patient with depression for synergistic effect? Yeah, that's very interesting. So typically, like if you use it in ECT, right? ECT is gonna like induce a seizure, which will increase intracranial pressure, and ketamine also does that. So I don't think you would want to use ketamine as an anesthetic in ECT like that. I think that can be a little bit risky, especially if you don't even know whether the patient has like intracranial aneurysm or arteriovenous malformation. Like I think if you really want to do this, you must be very careful and take due precautions and at least get an imaging to kind of rule out any intracranial lesion in the brain which could increase pressure. I have not seen any studies either in which ketamine was used like as an anesthetic in ECT. And also we don't really know whether ECT and ketamine combination simultaneously will be better than either treatment alone. But yeah, I think it's an interesting question for sure.
I would just add to that. I think it's very difficult to isolate the effects of ketamine when you give it as a anesthetic agent along with ECT, and many patients will have the ceiling effect in terms of ECT is already going to produce a lot of improvement. So how do you judge additional improvement due to the it's going to be difficult even if you have a comparator arm. So
I think the only way would be like one group gets ECT ketamine, other gets ECT propofol, but then I think you will need a very large sample to discern of significant.
The ceiling effect will come into play. Yeah.
Dr. Ramakrishnan had a question, I think. Is this correct?
Yes, Dr. Ramakrishnan, over to you. And perhaps we can stop with that then.
You have to unmute.
You're not audible, Dr. Ramakrishnan. No, we can't hear you. You are unmute actually, but I'm not sure why we're not able to hear you. No, we can't hear you. Sometimes it happens when you are changing the headphones. Maybe just disconnect everything and speak into the system as such, may work.
Okay. How about now?
Yeah, that's better. That's better.
Oh,
yeah.
Cool. Thank you. Okay. That was my question about the theoretical framework. I just proposed a journal session at the APA, next year's APA. The thing which we are working on is what is the effect, therapeutic effect that we have noticed is from the dissociation effect of the ketamine, which is causing the benefits in our patients. So we started working on understanding how to reframe the idea of dissociation in theological terms. And so with lack of the framework, the continued improvement will be lost. That's what we started thinking about, and we are writing some papers about that. Any thoughts on that?
I mean, I think there was a lot of kind of discussion and kind of debate in the literature on whether ketamine's effectiveness is because it induces this dissociation, and in which kind of people are able to kind of like see their depression in different light, like in a more acceptable light, similar to how how similar to how basically hallucinogenics are proposed to work. But there are also studies in which people have tried to basically block that dissociative effect, and there are also metabolites of ketamine which are being explored, which actually do not cause the dissociative effect, and yet it works. Like, for example, when you take ketamine orally, it tends to cause very little dissociation as opposed to when it is given IV or nasally. And still those studies have shown positive results. So I'm not sure if that is the entire explanation.
Thank you.
But to your point, people are actually using psychotherapy to pair with ketamine so that people can integrate that experience when they are having ketamine actively, and that has also found to have like very positive effect as well in patients. So
exactly.
I think probably are like you definitely have a strong point there, but I just don't have enough basically knowledge about that, whether that is essential.
Can I just 20 seconds?
Yeah, please, Dr. Ramakrishnan, we'll stop with that because we need to move on.
Yeah, thank you. This happened after I took ketamine myself orally with my supervisor, a professor in psychiatry, working on it. So with that, we came to that particular paper that we are case study. It's going to be a case study. So I'll end there. The effect was beautifully dissociative effect. I went through it personally. I could see that.
Sorry to say we have to move on, and Sujit, can you move on to the next speaker, please? Because if not, he's going to. Okay.
Thank you, Dr. Rishab, on behalf of all of us. Thank you for a great presentation.
Thank you, Dr. Rishab.
Thank you.
Thank you, Dr. Vikas. Thank you, Dr. Rishab. Now we are moving to the next session. Next session will be delivered by Professor Maheswar Satapathy, and it will be chaired by Dr. Vipul Janardan. So over to Dr. Vipul Janardan for introducing the topic and the speaker.
Good evening, everybody. Thank you for giving me opportunity to introduce Professor Maheswar Satapathy. He's the founder and CEO of the several respectable global organizations such as Global Health Forum, Global Brain, and the Mental Health Forum, and the world's largest only global consortium of the global health. He is a thinker led by the professional and led the Global South. He is Senior Research Fellow in the Institute for Global Health of University College of London, UK, and is also substantial faculty member at the Utkal University, Bhubaneswar, India. He is the director and lead of the Central of the Excellence in the Environment, Climate Change, and the Public Health Policy, a joint initiative of the Government of India and Odisha since 2023. He has a humble H index of 81 and the cumulative citation over 166,000. He has published extensively around 284, more than 285 peer-reviewed scientific articles and book chapters in journals of global and the reputable journals. He is a leading social thinker and the global health leader in the Global South. Over to you, Professor.
Myself, okay, thank you. So thank you so much, everyone. Thank you for the generous introduction. So I hope you are able to see me and hear me all right. Please, could you give a thumbs up? Okay, great, thank you. So the topic of today's presentation is Agency and Dialogue as Tools of Attitudinal Change Towards Mental Illnesses and Mental Health. global health policy implications for LMICs. So this is basically a little bit of critical attitude and perspective on some of the mental health care practices, as well as the theorization related to that in our global south. So okay. So mental health, as you know, has been realized as an important concern in today's world, but with a shifting focus to global burden of diseases, in which actually I have been also an author on many of those papers, and how much, means in the sense like we are quantifying the mental health and comorbidities. They contribute also to financially and by adding to the suffering and state of care. So a momentum spearheaded by the global mental health approach does promote acknowledgement of mental health issues as a reality that we grapple with. However, it doesn't tell us how much of that will be achieved, especially in nations which are still struggling, just like in our LMICs. Also countries which are facing issues related to the geopolitical order, instabilities and political instabilities. In LMICs, where most of the world's poor people and even world's people live, notion of health and well-being, and especially the mental illness, is still a subject attached with much stigma, right? I know that I'm coming from a pure pharmaceutical talk to a little bit of more global health and social science orientation. So I'm going to adapt a more critical approach to this. Health systems around these countries have historically witnessed an abysmal and unfortunate condition. In this regard, a rigorous analysis of 3 interrelated issues deem our reflection, and that's something which I'm going to talk about, and I'll wrap up the talk with a case study that we have done in Odisha. Though poor people suffer from depression, this is a debate that began way back a few years ago, where Derek Summerfield, a psychiatrist with National Health Service in UK, who has published papers on violence, mental health, etc., says that the symptoms displayed by the patient, like anxiety and happiness, they are basically are the result of poverty and cultural differences, not depression. In a debate with Vikram Patel, who is at McGill University, who is right now at Harvard, he said these are people who are struggling to find lunch for their children. But Patel's response is that poor people can also get depression just as the rich people. It's not about the rich versus poor, but mental health is equally and universally applicable to everyone. So the notion of mental health in LMICs, where in LMICs is a bit different from the global north. Healthcare professionals, researchers, as well as people in general are faced with a challenge when dealing with the mental illnesses. For example, eternal representation of mental illness in terms of its immutability, and the prevalent assumption has been that these hapless folks are devoid of control over their own desires, feelings, emotions, and hence the contingent action, disposing them to precarious modes of life and susceptibility to exploitation from different parts of the society. This traditional perspective is in line with an attitude which advocates regarding the lack of agency and free will. It means many people having or suffering mental illnesses do not have any agency and free will. This has remained as one of the biggest concerns for the health practitioners, and majority of the health practices have always emphasized on surveillance system and control check on the activities of the mentally ill, both suffering and the recovered ones. Unfortunately, the notion of global mental health doesn't render any meaning in this direction. So health and well-being, common knowledge and practices. What are the common knowledge and practices in global south? So there is a seamless stigma, outcasting, deep feeling of contempt attached to this issue, and overwhelming abhorrence of to these suffering people. There is presence of fear, anxiety, feelings of guilt among family members of the ill. The massive awareness on the issues is barely scarce and insufficient. Largely, the gap filled with superstitious beliefs and mythic representation. The mass consciousness is filled with prejudicial superstitious beliefs, derogation, and attempts to condemn the insane. Though the mental health movement has taken its momentum, but it has been majorly restricted to the professional's knowledge and professional domain. It has failed to reach the common man's cognitive repertoire. People really don't, engage much with the mental health as much as they engage with physical health issues like cancer or diabetes or heart diseases. Health and well-being, common knowledge and practices, individualistic approach to the healthcare in India. Mental health is purely individualistic, it's not very community-oriented. Is this system of glorified individual care really effective at all? This is a question that I would like to ask. I would also like to ask, are we able to care for the individuals proficiently at an individual level? And do we have trained specialists and professionals to deal with? This is a concern that has probably been prevalent in the majority of the global health system as well as public health system, and this concept we call care crunch. Severe shortage of resources also greatly limits the amount of care that patients and the caretakers can receive. It's not just patients who need care, caretakers also need care because there is a lot of caretaker burden. The individualistic care, though valorized, some of its aspects has its own loopholes. And first is majorly emphasizes on monopolistic and capitalistic system, which inherently advocates providing healthcare facilities to individuals, the garb of individual care and attention majorly to the affluent and those can afford. Okay. Second, the current prevalence system is very much limited by the degree and magnitude of its actual utility value as a byproduct of its lack of mass accessibility, urgent care system, and availability for the poor. So there are some mental health therapeutic needs in LMICs. 70% of the people in this country who need psychiatric services receive nothing. This is what Alan Kasdin said long ago. That number comes from several studies, including 2 published in the Annual Review of Public Health and JAMA Internal Medicine. The truth that we are not treating everyone in need, and we cannot do so if we insist on only one-to-one therapy at a clinic with a mental health professional. So what are the concerns? Recognition of a need, the demand. We need to understand and recognize the need and demand. We need to also work on the causal beliefs, lay health seeking beliefs, professional health seeking beliefs, cultural narratives around mental health therapy, etc. So what are the issues around paradigm of global mental health? Much of the narrative around global mental health focus on epidemiology and classical positivist approaches focusing on numbers as a mere disease cluster. These approaches, they fail to underscore the intersectionalities. I don't have the time, unfortunately, to explain the concept of intersectionality. I'm sure some of you or most of you heard of it. Cross-cultural diversity and complex yet beautiful multimodal interventions geared to deal with the psychosocial issues, which cannot simply be understood using such reductionist approach. This is unfortunately true. Ironically, there are several deeply cultural, professional, profoundly personal issues that surround mental illnesses in narrative, counter-narrative, subjective-based notion and madness, and how they are dealt with all over the world, and especially in the global south. Although it's seductively apparent that global mental health is benevolent, it's only to deceive under its garb of medical imperialism. Therefore, ontological realities of a developing nation and subjective notions around mental health and illness cannot fully fulcrum on a generalist pedantic notion of global mental health, as it almost negates minority perspectives, marginalities, subjectivities, equity, and development, much which come from global south. Issues around great divide between professional and lay. This is something which has been persisting after several decades. Although there is a lot of theorization and writing on this issue itself, but it has actually left the scene. And so, what are the issues? This becomes an important issue, especially when we talk about methodological realities as to how do we intend on having mental health for all under the UN's mandate for universalization of healthcare. And often when we talk about universalization of healthcare or universal health coverage, we really don't talk much about mental health. We often talk about other things, including the finance, health financing, and insurance schemes, and also how we can make healthcare available to all. But we do not actually talk as much about dental care and mental care. Both are severely ignored. In the recent years, with increased realization of the infrastructural scarcity and care crunch, NGOs have come up with multimodal participatory interventions in the community with the express purpose of spreading awareness regarding mental illness, and some of it has been also successful in eradicating the stigma and creating sustainable systems for community practitioner interaction. These sincere efforts with the use of health literacy efforts have emphasized on increased community participation, the role of a user-driven healthcare planning and delivery reorienting, are focused to the agency and participatory dialogic praxis. I'll explain what is participatory dialogic praxis in the next few slides. This paper with an basically aims to address the need of breaking the boundary between the elite professional authority and the lay recipients of care, and the possible potential role of civil society NGOs that can play in bringing the agency in persons with mental illnesses to free-flowing dialogue, its implications for health policy planning and delivery, especially in a country like India. And I'll also treat the case. So what is praxis? Praxis basically refers to a process of critical intellectualizing and internalizing of cultural attributes while allowing for sufficient reflexivity, whereas dialogue leads to critical reflection, first step of the practice, coming from Paul Frederick, and instrumental in developing one's cultural and situational consciousness, coming from Dorsey. Okay, so critical reflection and reflexivity, which are not the same, one can decide on and conduct themselves of appropriate action, which mostly moderated through a cultural consciousness for determining the appropriateness of the response. Hence, culture and society plays an instrumental role in one's introspective abilities, degree of empathy and self-reflexivity, etc. So here, participatory practice is basically committed to mainstreaming the voices of the poor and marginalized section of the society and everyone who is basically not having any voice in the process. So what is prefigurative practice? Prefigurative practice basically emphasizes the relationship between action, research and practice and the creation of alternative to the existing social order. So I don't have a lot of time, so I'll be very fast. Participatory dialectic practice, it's basically the dialectical relationship between people and systems that Seidman suggests offers a ground for increased dialogue and voicing of true concepts of community members. This kind of relationship emphasizes on a true relation of the needs, concerns, challenges, strengths and opportunities present in a particular community, and we will also take it as an indicator of designing programs in consultation with the community. And so obviously community plays an important role in the decision making and also policy making as far as the healthcare is concerned. So for the optimal realization of such changes with active arguments from community development agencies, whether the government, non-governmental organization, community-based organization, or other civil society organization have to define or redefine their roles as facilitators of such participatory processes in development. And the same can be also used in mental health care. This is something which has not been very actively used. So engagement with development agencies and organizations is a critical component of participatory development advocacy. However, many a times that has been used in development studies, but not in mental health care. So dialogue agency and experiential learning is something which is very much at the heart of community mental health, and that needs to be taken more vigor. Action and agency in dialogue. Obviously, action agency plays an important critical role. So what happens when people communicate or dialogue with each other? This is the daunting question that this book proposes to ask in this particular book. We have paraphrased here Austin very long back actually, because most of what we are talking about is coming from community development and international development perspective, but not much has been used in the mental health care. And we have used that model here, and we have tried to, I'll skip a few slides so that I'll just skip a few slides so that all of you can go ahead. You can see this. So Francois Coherent helps to explore the unexamined assumptions about our experience with non-humanities. In a detailed study, he talks about who holds the agency, and he also talks about what can we do about it. So I'll not go in detail related to this because this is not actually essential here. But I will definitely like to focus on collectivism versus individualism versus mixed isms. Why? Because many times the global South and North are opposed as if they are basically different models of each other. So contribution of lay knowledge to the understanding and promotion of mental health is something that has not been talked much. There is a huge amount of trust in the biomedical model and authority. Authority, that means surrender. Does this negate and corrode one's agency? Maybe, and still maybe not. And we also need to talk about indigenous knowledge co-production, which is very much ignored. Then there is agency in engagement. What are the factors, shapes, and outcomes? We need to talk about that. There is a lay professional alliance, dialogue and engagement as roots to agency. That is something that we also need to focus on, and that is something which we have tried to use it in our scheme. So are the lay partners ready? This is also a question that begs attention. Why? Because many times we assume that the lay partners, many times, first of all, they are not even given the due acknowledgement that they can act as a partner, because professional dominance is too high and heavy in the mental health as well as in healthcare setup in particular. And when we are talking about capacity building on depression, which includes familiar nomenclature, biopsychosocial elucidation of the illness, lifespan approach, life course approach, understanding of its impact on various domains of functioning and the treatments, I think we need to go beyond our traditional models of treatment. We also need to form a therapeutic alliance and assemblages, and we also need to understand the tensions and contestations which occur as a result of that. The therapeutic alliance is a critical determinant of individuals' persistence and outcomes in mental health treatment. Simultaneously, individuals' community networks have decisions about whether, and when, and what kind of treatment are used. Despite the similar focus on social relationship influence for individuals with serious mental illnesses, this line of research has maintained an almost exclusive focus on either inside treatment or networks or outside networks, respectively. So why alliances don't foster? Because deep-seated insecurity of the professional, challenge to hegemonic power structure, agency opposed to authority, voices opposed to silence and domination, culture shift causes tension and conflict. For example, Patel's suspicion is that the professional community was threatened by the use of paraprofessionals with comparatively light training, which some of his studies in India with Sangat and other organizations did. And that is something which I would also concur based on my work. So collaborative engagement, the tridents, there are 3 tridents here: survivors, professionals, and consumer. They can all come together and they can do a lot. So there's a shift. We need to stop being obsessed with the artifacts of psychiatry to post-psychiatry mix now. Okay, this is the model that we developed in 2010 and finally got published in 2 different papers, 2010 and 15. This is the model that we have used to bring multi-stakeholders to come together, the community being at the heart of it, the family and relatives and individuals with mental illnesses, and those who are survivors or those who are basically being recovered from the mental illness. So what are the aims and rationale of this approach? To instill values of competence, emotional and psychological, and empowering the community gradually by reassuring of their strengths, heighten the degree of resilience among the adversaries of the social situation or in any trauma undergoing the psychosocial crisis, enabling them with the positive armor to protect them from the pessimistic forces and to create forces within the community, which will be basically encouraging them to become radiating energy, etc. It means basically support. Sharing personal experience and concerns, seeking solutions to the community can be helpful. I have borrowed a few anecdotes from some of our work. So now let me take you to the field study which we have done. This is a very longitudinal study. This is not recent study. Okay. There is a few questions, comments coming. I really don't know. Okay. Your slides are not changing. Why are they not changing? Okay. I have shared my screen. Maybe I can do one thing. I will stop share and I'll share again. Yeah, that's all I can do. Because they are changing at my end.
Now they are changing. We are stuck with the slide number 13. Now it changed to 31 suddenly. So now you can proceed.
Okay. I'll just show the model that, can you see the model right now? No, because I have stopped sharing.
Yeah, you have to share it.
Yeah. Okay, sorry. Okay, I don't know how that happened, but I hope you can see the slides now. Yes.
Yeah. Now the model is visible.
Yes. So the model that we got published in 2010 and 15 twice, and this is a model at the heart of which basically there's a lot of integration of communities, people surviving from mental illnesses and people who are actively also going through some form of mild illnesses at the moment. So this is the map of Odisha, my state, at least urbanized state of India. However, it is also growing very fast nowadays, which is probably giving us mixed feelings all at the same time. So I would just go ahead in this form. Maybe it will show properly. I really don't know why the slides have come. Please let me know if the slides are moving now. Can you see this new slide? Hello? Can you please confirm if you can see the new slides? Yes? Okay. To the new slide where I'm showing the putting indigenous mental health into perspective, because Odisha, the state that I belong to, has more than 62% of the original 60 types of tribes, and few of the most tribal people, it means indigenous people, live in our state itself. So I'm going to present you a case study in one of the tribal places. It is a case study on a particular residential care home called Janani, a home for survivor women. From Chaudhar, Cuttack, Odisha, is a home for mentally challenged women, girls from socio-economically whose backgrounds they stay there. Most don't have a family anymore and were left abandoned. So obviously, most were rescued from different parts of railway stations, trains, and other parts while getting trafficked, and is built on a 15-acre land surrounded by mountains and villages with farmland and offers natural and sustainable ecosystem. Beautiful ashrama engages the residents of life, building on productivity, the work and help in the culture, and many green vegetables, and also create place with nature's best support. So here I'm trying to talk about one concept called communities of care, because here this is particularly applied in this particular community-led effort. So we are now also talking about, can we build communities of care for them? Communities themselves will be operating as safe and enforcing, will also encourage each other with on their positive strengths and help achieve ultimate resilience. That is a question that we have been asking, and we tried to do this. And I think over the past more than 10 years, 12 years, I think we have been able to get some sense out of that, because most of the residents who are living in this community-led home, they are
Hello. Thank you, Professor Maheshwari, for the powerful. Hello. Is Professor Maheshwari is there?
Dr. Maheswar is there online. Professor Maheswar Satapathy is there online.
Okay. Yeah. Apologies, I was cut off for a minute. I am going to screen share again. So I'm also going to turn up my camera in case the internet might improve. Okay, so here I'm going to show some of the pictures from our Janan Ashram in Chaudhar, Odisha. The producers, entrepreneurs, co-creators, co-system, where women who have been suffering from several mental illnesses are now recovering and are on a path of self-discovery and growth. And they are also co-producing in these farmlands. I hope you are able to see my slides. Can you please give a confirmation?
Yes, sir. You can. We can see.
Okay. Okay, thank you. So the next slide, which I'm showing, proud producers of vegetable, because we regularly visit them. Previously, we used to visit them twice a week. Nowadays, we are visiting maximum once in fortnight, because there are some other members who are also taking care of the thing. So in this particular ashram, there is around 10 acres of land is purely used for agriculture, and they are producing vegetables which are consumed and is also sold out at villages who are living nearby, and that is being produced by all the community. And let me tell you, this this particular residential home has more than 200 women who are living there, and they are very, very active in terms of their day-to-day activities, and they're also extremely jolly nature. They interact very, very. We get affection and love on us, and as you can see clearly, they are very actively engaged in the harvest, harvest of hard labor, and they are very proud entrepreneurs also, because some of it is also getting sold and money is getting generated for their care. Then there is also joy of cooking, because when we visit, we always cook, and there is a meal, collective community meal together. We have meals. The houses have been recently built. Some more houses have come up. This is a little older picture. So they cook, they serve the food, and we eat together. We interact among each other. As you can clearly see, this was from one of our visits, and we have cooked, and we also feed, and I think there is a sense of community that we try to foster here. And we also take some of our students from time to time, just so that they can observe and engage with them, and they will learn. And many students from psychology department, other medical sciences, public health department, they also visit us, and they experience firsthand as to how to deal with people with mental illness and mental health issues. And that's something sorry, very essential for all of us to understand. And this is just one of our core team members, Dr. Anna, and one of the persons who is very happy that such kind of activities are happening here, and so many young people are coming to visit them on a regular basis. These are the residents of the community, and true engagement builds on equality. So without having a true equality at the heart of it, I think we will not be able to make any progress. And this community, this experience of over past more than one decade, which I have had with this residential care village community, I think it has paved the way. It has also helped me to evolve as a professional, also as a person, in a great deal. And I have learned so many important values and principles. And we try to encourage voice and agency of all the residents in this place. And as you can clearly see, they are always available with us, and many of them actively interact with us, very actively. And they crack jokes, they tell so many important stories about their lives and many things. As you can see, there is a mic, a person is holding the mic, the girl is holding the mic, and she is talking something about some of the things, and she also sang a song during this particular meeting. So basically, our model focuses on 4 things: a continuum, our journey towards building agency. So we start with engagement, we go to dialogue, and then partnership. We build partnership, and then we try to foster agency among people who have somehow lost it due to the pressures of the society, and also the debilitating effects of mental illnesses. What are the unique strengths of Global South? So we need to talk about it, because our effort lies in Global South. collectivism. We have a huge amount of collectivism in the Global South. I think that is our core strength. The stronger family system ties, they are extremely useful. Community orientation as a default is our core forte, and I think we need to build on that. Mental health as a part of well-being agenda can be included, and community participation and support is higher. Cheaper and cost-effective means of care are possible in our context, and we need to build on that, and we need to foster that. Cultural innovations into therapeutic needs to be integrated, well integrated. I think psychologists, psychiatrists, and all other mental health professionals, everyone who is dealing with neurological and mental disorder, they need to work together so that they can work on it. So how do you grow? We need to grow on complementarities, not contestations. So we need to focus on pluralities, subjectivities, multiplicities of voice and identities. We need to build on engagement, dialogue, and partnership between different stakeholders. We need to listen, and lots of active listening. So global partnership focusing on a combination of global and local model, which we call local models, converging to produce a global conglomerations, and assemblages entangled around intersectionalities need to be built into our systems of care, as well as everything that we do into therapeutics. We need to focus on articulation and not silences. We need to focus on building a team, not building onto the power structures that we have that have been deeply embedded into the system. We need to learn from each other with a paradigm shift. Rather than building on like we are experts and they are lay, we need to come together and need to work together to make a change in the collective attitude change. So we need to move from individual to community focus on orientation. We need to be serious learner observers to experience knowledge, and we need to also move beyond the global north led dominance to global south examples and create exemplars in mental health care. And we need to move beyond best practices to integral reflexive practices. I think that with that, I would like to sum up my talk. Thank you so much for the opportunity. It was wonderful to come here. And thanks, Reynard. Thanks, Dr. Sujit, for this brilliant opportunity. I think all of you are doing brilliant work. Thank you so much for the opportunity. It was lovely talking to you.
Thank you, Professor Maheswar, for powerful reimagining of global mental health. Your call for decolonization and the locally rooted approaches resonate deeply with the realities of LMIC. We are reminded that the health and the well-being cannot be imported. They must be co-created with the community. The shift from the professional hierarchies to the dialogic participatory praxis is not just desirable, it is urgent. As we move to the system strengthening, your insights set the perfect stage for rethinking human capital in the global south. So I just want to put to all the audience for any of the questions they want to put on. Thank you so much.
Thank you. If anyone wants to ask any question, you may please kindly ask me. I will be very happy to respond.
So how do you think? Sorry, thanks for this very exciting talk. Thanks for this very exciting talk. It's Rainer here. Hi. And I would like to say, how do you think you can spread this? I think it's a very welcome, but I think we had something similar from a talk about Kenya, where they're very much focusing on the community. But how would you strengthen that, and how do you move forward in this approach?
I think one of the ways it is possible is if we try to scale it up across the breadth and length of the country. Let's say India is with 1.5 billion people. If this is an exemplar in mental health practice, community-led mental health practice, I think we scaled up, it can be widely, taken onto larger scale by taking more out. Possible if we work with the civil society and individual survivors of mental illnesses and their caretakers. That is only possible if we harbor on the strengths of communities. So unless we take the communities on board and their shared decision making, and their power of collective, we will not be in a position to do it all on our own. Even a state or government cannot actually implement it. Like if, let's say tomorrow, government of India or government of Odisha decides that we'll create 200 Janani homes over Odisha, but still it will not be sufficient. Why? Because there is not much of integration of the community and community voice, community-led decision making, and community being at the heart of it. So community needs to be at the heart of it, and that will be the only way all these kind of ways or systems can be integrated. Depends.
So I think if there's no other questions, and I think you're very busy, and you're going to another meeting, Professor Maheshwar, and thanks a lot, and yeah, thanks for your contribution. And I would like
Thank
to
you.
thanks a lot. I'd like to ask Dr. RUTH OWUSU-ANTWI to share her slides and maybe unmute herself. And maybe in the meantime, I can introduce her. Ruth, are you there? Are you available?
Yes, I'm ready to go. Thank you very much. I'll share
All
my
right.
slide.
Okay, if you share your slides, in the meantime, if you share, if you also show your video, and maybe I can just introduce you. Dr. RUTH OWUSU-ANTWI is a fellow of the Ghana College of Physicians and Surgeons and a senior lecturer at the School of Medical Science at the Kwame Nkrumah University of Science and Technology. She practices in Komfo Anakoye Teaching Hospital at a senior specialist level, and she is the immediate past president of the Psychiatry unit. She is medical director at Recovery Pathways, a renowned private practice that specializes in outpatients and inpatient mental health care and other and offers employee assistance programs to several institutions. She has won many awards in the field of practice, including 2019 International Fellow of the Association of Women Psychiatrists in San Francisco, 2005 National prestigious Millennium Excellence Awards, and she's working on women's mental health. She's immediate past president of the Ghana Association, and she has been very important in the Psychiatric Association of Ghana. She has over 13 publications in peer-reviewed journals and published book chapters. She's a Christian married and has many biological adopted children. And her talk today will be on the prevalence of gender-based violence and factors associated with help seeking among university students in sub-Saharan Africa. If you put your video on, are you willing to do that, or are you on? Can you?
My video is already on.
All right. Okay, that's perfect. Okay, so yeah, Ruth, thanks for coming, and thanks for starting now. Okay.
Great. Thank you very much. It's nice meeting you all. And well done for putting this program together, especially Professor Rainer and the rest of the team. I am grateful for this opportunity to talk about some of the work I have been doing on gender-based violence. Like my name was mentioned, I'm RUTH OWUSU-ANTWI. I come from Ghana, West Africa. So I'll be talking about the prevalence of gender-based violence and factors associated with help seeking among university students in sub-Saharan Africa. So I work with a group of researchers. We call ourselves Sub-Saharan African University Gender-Based Violence Prevention and Response Network, SUBVET for short. And the group entails people from different countries. Now we have over 15 countries on board representing different universities in different countries, mainly in sub-Saharan Africa. The group has been in existence since about 2016 2016, but I joined in 2015, and our focus has been on gender-based violence, especially in the university. Our latest work, which I led on that particular project, was looking at the prevalence of gender-based violence and factors associated with health seeking among university students in sub-Saharan Africa. And I would delve more into that as I go into my presentation. Our work was published in the Women's Health Journal. This particular work. So by way of introduction, we know WHO has defined gender to refer to characteristics of women, men, girls, and boys that are socially constructed. This include norms, behaviors, roles associated with being a woman, man, girl, or boy, as well as relationships with others. And as a social construct, gender varies from society to society and can even change over time. Additionally, gender produces inequalities that intersect with other social and economic inequalities. WHO has defined gender-based violence, therefore, as being a major public health issue worldwide, and defined it as violation of human rights driven by inequalities between men and women in society. We know the effects of gender-based violence, but primarily it potentially has significant long-lasting physical and mental impacts, including injuries, unintended pregnancies and pregnancy complications, sexually transmitted infections, HIV, depression, and post-traumatic stress in survivors. Interestingly, gender-based violence is one of the public health issues that has been seen to occur everywhere in the world. There is no part of this world that issue of gender-based violence is not a concern. So currently, gender-based violence is a global public health problem occurring across geographical and cultural contexts. Evidence from across the globe suggests that 25% of women and girls will suffer from a form of intimate partner violence or non-partner physical or sexual violence in their lifetime. That is more than 1 out of every 4 girls. 1 out of every 4 girls. That is a staggering and worrying statistics there. According to the same evidence, 33% of women, specifically in sub-Saharan Africa, are expected to experience some form of violence at least once in their lifetime. And so when you come to sub-Saharan Africa, more women are predisposed or at risk of experiencing some form of gender-based violence. About 1 out of every 3 women. And currently, the sub-Saharan region has one of the highest prevalence rates of lifetime intimate partner violence worldwide. So this is a global map showing regional prevalence rate of intimate partner violence, which was put together by WHO. This was a map put together in 2010. And we realized that every part of the globe has some percentages ranging from 37% through to 29%, 24%, 23%. So every part of this will tend to suffer some form of gender-based violence. Now, gender-based violence comes in several forms, and it includes intimate partner violence, which can be physical or psychological. It includes sexual violence, and it includes stalking. Gender-based violence has resulted in a lot of negative consequences and numerous aspects of health and wellness. And some of them are the fact that GBV results in acute and chronic conditions or health conditions. It can lead to chronic pain, it can lead to digestive problems, and it can even lead to cardiovascular diseases. Again, GBV can result in psychological health issues, resulting in disorders like major depression, anxiety disorders like post-traumatic stress disorders, etc. It also leads to complications in the area of reproductive health. We have had specific complications like maternal miscarriage, sexually transmitted infections, etc. Additionally, individuals who experience gender-based violence can suffer from economic and social outcome. And the ultimate complication and consequence of gender-based violence is suicide and eventually death. What are the well-known risk factors for gender-based violence? Low self-esteem, low income and unemployment, low academic achievement, and that is one of the reasons why we targeted our study among the academic institutions. We realized that if we're able to target one of these risk factors, it may be one of the ways to reduce the incidence and the prevalence of gender-based violence. Young age is a risk factor. Aggressive or delinquent behavior as a youth, substance use, depression, antisocial personality disorders, desires for power and control in relationships, history of experiencing poor parenting as a child are all known risk factors for gender-based violence. And let's look at some specific factors, risk factors for gender-based violence. When you look at relationship factors, marital conflicts, fights, tension, and other struggles are a major risk factor. Marital instability, like divorces, separation, economic stress, unhealthy family relationships and interaction are notable relationship risk factors for gender-based violence. When we group the risk factors into community factors, we have poverty that is usually associated with overcrowding, low social capital, lack of institutions, relationships, and norms that shape communities' social interaction is a risk factor, and weak community sanctions against intimate partner violence or against gender-based violence. There are some neighbors who consistently hear beating in their next door neighbor's house. They constantly hear fighting or sometimes actually see and witness fights between couples or intimate partners, and they are unwilling to intervene because they think that it's not their business. When we continue to look on some of these things without caring, without concern, then as a community, we are perpetrating gender-based violence. There definitely are some cultural factors that have been linked to gender-based violence. We have, as Africans, our traditional gender norms, like women should stay at home, women should not enter the workforce, women should be submissive, and that men have the final say in families, and that it is men that make all the decisions in families, are very ingrained cultural factors that subtly promote gender-based violence. Now, zooming into gender-based violence and university students, having said that gender-based violence is a global public concern, universities are not spared. Whilst research exists on gender-based violence and its associated health-seeking behavior among university students, there are few studies that have been done to assess the prevalence of gender-based violence, including experiences and barriers to health seeking within the sub-Saharan African university setting. So our study was unique in terms of the fact that it involved higher education participants. And we know that when people achieve some form of higher education, it has a unique characteristic that shape the individual's risk of gender-based violence. For instance, ideas of female inferiority on university campuses in itself exacerbates the power imbalances between women and men on campus. Simple positions like Students Representative Council President, or what we call the SRC Council President, or student leadership positions, or student union leadership positions tend to go for men, or tend to be given to men more than women. And these are university campuses where we are shaping the lives of our students, our young men and women. And if at that point where proper education is supposed to take place, we have these cultural norms still entering, then we increase the vulnerability of the female students to gender-based violence later in their lives. And that is not all. On university campuses, we are very much aware of how gender-based violence is perpetrated by people in positions of authority and influence, how they exert influence over students, female students, such as the male faculty and university administrated in exchange of grades and etc. And so it's important that we focus on gender-based violence in university setting, because it is widely recognized that education is one of the most effective strategies for reducing poverty and improving health in low and middle income countries. Universities have a duty to create a safe campus environment that fosters students' learning. However, the gender-based violence in these university settings is undermining the ability of these institutions to uphold the right to education and to safeguard physical and mental integrity of our students. We found some campus level factors that put students at the university specifically at risk of gender-based violence. Some of these factors are the fact that these students are living independently for the first time and away from their parents, away from parental control. This is a gathering of young men and women, and so you can expect peer pressure. We realize that the lack of formal and informal parental control is also a unique risk factor. And then the normalization of substance abuse on campuses are all factors when combined with culture, normalizes sexual violence, accepts rape myth, and promotes hypermasculinity that can result in gender-based violence on campuses. Further, we further found out that a systematic review indicated that the exposure of students to gender-based violence when they are on campus has a negative impact on the students' educational path, and it affects their academic performance, it affects their attendance to lectures, and specifically results in high dropout rate, changes in the field of study, it results in academic disengagement, it results in changing in educational attitudes and satisfaction, and it results in changes in academic climate. And so considering all these adverse effects of gender-based violence in university setting, receiving formal or informal sources of help is thought to be essential to mitigating the effects of gender-based violence and improving health outcomes and well-being. Research has shown that in African countries, the rate of women who seek help after intimate partner violence is very low. For example, there was a cross-sectional analysis in sub-Saharan Africa that found out that among women who experience IPV in the region, only 39%, like about a third, have sought some form of help, with some countries having a prevalence of as low as 20% of these women seeking help. So what did we do? The surveyed group decided to examine the prevalence of gender-based victimization and help-seeking behaviors of university students from universities across sub-Saharan Africa. We involved about 6 universities universities, and we sought to understand the experiences and barriers to help seeking, as well as some demographic factors that were associated with informal and formal help seeking. And we sought to find out how we can help university responses to support student survivors of gender-based violence. So specifically, we sought to do three major things: to identify the prevalence of gender-based victimization among students since entering the university. Secondly, we sought to describe help-seeking behaviors and barriers among students who self-identified as having experienced gender-based violence. And then lastly, we sought to examine some demographic factors like age, gender, sexual orientation, religion, university, or country that were associated with formal or informal health seeking. And so we designed our study by using an online cross-sectional survey study, and this was administered to universities online between the months of July to October 2023, initially at 9 participating universities, but due to data inadequacies, we involved only 6 countries in the data analysis. And so in the analysis, descriptive statistics were used to describe the types of violence among students. We took data from 2,249 students, and we used several other statistical analysis to examine the demographic factors associated with informal health-seeking behavior among the sample of gender-based violence. So these were some of our findings. A total of 63.7% of students were reported stalking victimization. 18% of our students, of our sample students, reported sexual violence. 30%, almost 31% reported physical violence, and then 64.9% reported emotional victimization among our sample size. When we looked at the results on the help-seeking behavior, we realized that majority, up to 78% of survivors who sought informal help, they sought it from friends, partners, family members, and religious leaders. And approximately a third, that is 29.5% of our students, sought help from formal sources like the university administrators, healthcare professionals, or the police. But many students reported barriers to seeking support for gender-based violence. And the most common barrier that included the students, included the student not knowing where to get help at all. And that accounted for about 32%. And then the other barrier was that they did not believe their situation was as bad or as serious enough that warranted help. And that accounted for 28% of the barrier. And then the third common barrier was the fear that others will know that they have become victims or they are survivors of gender-based violence. They feared being judged. They feared the stigma that goes with gender-based violence. And that accounted for 34% of the barriers to seeking help. And so some of the conclusions that came out of our study show that the prevalence of physical violence among our sample was 30.9%, out of which 18 was for sexual violence, 64 was for psychological violence, and 63 was for stalking. And then among the sample who had experienced gender-based violence, most of them, up to 78% of them, preferred to seek the informal help, which were basically from friends, partners, or family members. And just 1/3 of them decided to seek formal help. And again, our results indicated that the university country was associated with formal health seeking. That is, specifically universities or students who were universities in Ghana and Rwanda were twice as likely to seek formal help than students in the other countries. And then while differences by gender were noted also in the formal seeking, help-seeking behavior. Still, part of our conclusion on this study tells us that gender-based violence is a significant public health issue, specifically among university students in sub-Saharan Africa, and that most sub-Saharan African university students are seeking informal support after experiencing gender-based violence due to commonly perceived barriers as not knowing where to go, not believing their situation is serious enough, and it means that education on gender-based violence is very low and poor among our universities, and also people were concerned about stigma when they seek formal help. And as such, efforts to address gender-based violence within university settings in sub-Saharan Africa should be coordinated to maximize opportunities to share lessons learned, best practices, and the expertise and disciplinary perspectives of diverse administrators, faculties, and students in prevention development. I would end on this note by saying that domestic violence or gender-based violence typically recurs and progressively escalates. The ultimate result of domestic violence may be death from suicide or homicide. We should not keep quiet. We should empower our patients, and we should by all means educate them and show them where to seek help. Thank you very much for your attention, and these are some of selected references to my presentation. Thank you.
Yeah, thanks a lot for this very interesting talk. If there's questions, I think if there's some in the chat, I hope you can hear me. Well, you can't see me, so, okay. Right, okay, sorry. Yeah, thanks for this very interesting talk. And I'd like to, ask for questions. But if there's nothing at the moment, I would like to ask myself or ask you, yourself, how does the current media, how does it influence the perception of violence? Because let's say in Great Britain, we have more and more reports of stalking, and people are, media celebrities are presenting their cases. So that does it have a positive impact on the perception? And the other thing is possibly stalking is something which gets worse under all these media. And so what's the current development? And so is there any, especially is there anything you have asked about these media influences of that?
We have not specifically studied the effect of media on gender-based violence like stalking, specifically in sub-Saharan Africa in our study, but I'm sure there are published studies out there that the more people get to report and speak about it, the more people get to know that these things are wrong. We realize from our study that people at the highest level of education, which is tertiary, did not think that there was anything wrong with gender-based violence. They did not think that stalking was a problem. They did not think that emotional abuse was a problem enough to report. And that shows a low level of education among people who are expected to be the most highly educated in our institutions. And so some of the role the media can take up as they make these reportages is to take an opportunity to educate the populace that these things are wrong. People need to report. People don't have to keep quiet. They need to seek help as well. And it's one of the ways that will gradually lead to reducing the prevalence of gender-based violence. Thank you.
Yeah, so there, some people say you had a wonderful presentation, but there's also a couple of questions. Do you think medical doctors need training to recognize gender-based violence early?
Definitely. I, as a person, do a lot of courses among my colleagues to train them on how to recognize early gender-based violence. If you are in the consulting room, mostly a family physicians or the family doctors are usually the first point of call for people or who are survivors of gender-based violence. And we teach them most of the red flags. Sometimes people come just repeatedly with bodily pains or repeatedly with non-specific symptoms that laboratory investigations do not reveal any specific diagnosis. Sometimes a particular patient consistently come to the consulting room trying to cover up their physical injuries by wearing really broad sunglasses or wearing very thick makeup to cover their injuries, or sometimes wearing clothing right up to their neck so that their injuries on their neck will be covered and all of that. And you need to have a high index of suspicion when some of these non-specific complaints from a particular person keeps coming, or people come to the consulting room wearing sophisticated clothing and makeup, probably in an attempt to cover their physical injuries. And so these are things that we need to consistently teach doctors to pick up early, because it is very difficult for survivors to willingly report issues of gender-based violence. And it's important that doctors learn to initiate that conversation and make it comfortable for survivors to freely talk about the troubles and the pain they are going through and to seek help.
I think there's a question which relates to that from Dr. Basu. She has, or he has encountered patients who are backing out at the moment and when they suggest any more actions. So how do you really persuade? So what is your approach to persuade people to report?
What I have done in my country and have found to be very helpful, I don't have the statistics readily available, but there is an obvious measure of how this particular approach has helped. So what we put together, first of all, we observed this very same problem back home. We realized that the person starts talking about their problems, and then you tell them, if for instance it is a sexual abuse, you tell them go to the police and get a police report, or go and see the obstetrician gynecologist to confirm that, to be examined, to confirm that there was actually a rape, go and see the clinical psychologist. So this particular one patient who is already dealing with the trauma of the violence keep reliving their trauma by telling their story over and over again at different places to different specialists, and monies are collected from them, pay for this, and they become really exhausted. Most of them give up. So what we sought to do is what we decided to set up abuse clinic, survivors of abuse clinic. And these are clinics currently in 2 major cities in the country. We have one in the leading tertiary hospital in the country, Kolebu Teaching Hospital, and then the second one I set up myself at the second biggest teaching hospital where I work, which is the Konfanochi Teaching Hospital in Kumasi. So this survivors of abuse clinic is a one-stop clinic that you would get all the support that you need for every kind of abuse, and we see both children and adults, and we have about 14 different specialists in the clinic. We get people referred to the clinic so that we book them for a specific date, so that based on the referrals we have gotten and the nature of the abuse, we get our team together. And so these 14 specialists entail a psychiatrist, a psychologist, an ethicist, a human rights lawyer, a police officer, or back home, we call them DOFSU group. We have an obstetrician gynecologist, we have an emergency physician, and we have an art therapist, several other professionals in that group. And when you come, you tell your story just once, and then it is moved across the various specialties that you will require their help. There are times that patient cannot pay for legal help. We have legal aid, which provide free legal support to our patients. And it has made it possible for people to follow through to getting help. So these are things or approaches that I recommend for people to put together at their setting.
Maybe a quick question. Is there any difference noted between IPV among people who are married or unmarried? So is there any differences which, interrelationship?
So IPV occurs across all forms of relationships, including the married, including the cohabiting, including the different kinds of relationships, whether homosexual or heterosexual. IPV exists almost equally across board. And so these are real things happening in all forms of relationships where love was supposed to be the focus, ending up in abuse.
Okay, I think there's someone, right, Monica Thakur, do you want to ask a question?
Yes, sir. Actually, it is similar to the answer given by ma'am. So good evening, ma'am. My question was the difference. Basically, I have come across such patients where when a female is married, at that particular time, I have observed the stigma is slightly more. And since it's a social relationship where people know about it, so somehow, the sexual kind of violence and physical kind of violence, people either observe less, and when they observe it also, at that moment of time people do not want to report it, and it goes in general unrecognized and then neglected further. So that was my question, whether any sort of stigma is observed in these kind of people, where maybe among married people it is more, or it is more among the people who are not linked with any sort of relationship. Further, if I observe such patient in my clinic, and I know that this is a legal kind of issue, whether I should advise for them to seek legal help, or shall I be in my boundaries? What should I do? Because this not only happened with the gender-based violence, but with multiple, kind of people. And this one particular patient, I have observed where she dropped the treatment the moment I recognized that the violence is involved, and it's a physical violence and it's a sexual violence as well. And unfortunately, she have taken treatment from 5 to 6 center before, and once I recognized that, post that, the partner of her, since she was dependent financially on him, she dropped out of the treatment. Otherwise she was improving a lot. So in that case scenario, what should we do? And what is your observation for that?
Yeah, thank you very much. Yeah, so when people are married or are in married relationships, the perceived stigma of gender-based violence is even higher. And it's been more difficult. In my practice, I've realized that it's been more difficult for married people to seek help for the gender-based violence, mainly because of cultural and religious reasons. You don't know whether you are reporting to leave the marriage or you are concerned about the stigma that you went into a very bad marriage and all that. And mind you, it is not only women who are survivors of gender-based violence. There is some percentage of men who also are survivors or who are also on the victim's side. And when they are in a married relationship, I have observed, you are rightly said so, that the stigma, the barrier of stigma in terms of seeking help is more. And then you asked whether when you meet a case in your clinic, is it your duty to report or not? And it's a big yes. I'm not sure your country's laws, but in my country, in Ghana, gender-based violence is an offense. And so for you to meet a case like that and not report, you are sort of seen to be aiding and abetting or sought to be seen to helping a crime or an offense perpetrate. And so it is your duty to report. In my country, we have a specific unit within the police system that specifically handles gender-based violence. And what we have done in my country in terms of the survivors of abuse clinic makes it even easier for us. We just contact our police personnel on that clinic and then involve them directly from there. I have had people or victims who have pleaded that they don't want their husbands to be arrested and all that. And you can understand because they can't see how their partners or their husbands will be arrested, and then who will feed the family, who will feed the children and all of that. It becomes a very dicey situation, and that is why we seek to empower women also through education so that they don't have to depend on men. When there is poverty, gender-based violence thrive and worsen. Again, our survivors of abuse clinic has made it easier for women who may not be well employed or who may not have enough financial strength to get some help, because all the help that we give at one standing is usually sponsored by well-meaning people. There are times that we have to move these women out of danger into halfway homes, and we have had volunteered doctors or doctor couples who have signed on to accommodating some of these survivors for a period up to 3 months, whilst both the individual couples get some counseling and get some professional support. And so we do not promote divorce, but our aim is that at some point in time, when your life is at risk, we need to remove you out of the danger so that you don't lose your life. And so we would recommend that you separate from your marital home and get some help. There are no national government halfway homes, and so we have had to use volunteer homes for that purpose. And so that is how we have been managing it back home.
Right. Okay. I think it's a very exciting discussion, and sadly we have to finish now. Thanks so much, Ruth, and I'm so grateful for your talk. And yeah, thanks a lot. And sadly we have to move on. Maybe if we can continue another date for that. And you're very welcome to join for the next sessions, but I think you are busy in Halifax somewhere in the north. Okay. Thanks so much, and thanks
Thank you for having me.
Okay. A great pleasure. Thanks a lot. And I forward now to Sujit.
Thank you so much for a wonderful presentation. Now I will request Dr. Prasad to chair the next session. The title of the next presentation is Artificial Intelligence Used by Medical Students, an Indian Perspective. Will be presented by Dr. Surobhi Chatterjee. Before Dr. Prasad will introduce the speaker, before that, let me introduce Dr. Prasad Reddy, who is a faculty member in the Department of Psychiatry, King George's Medical University. He is the Faculty of Psychiatry Social Work. He is involved with a lot of psychosocial rehabilitation for patients with mental illness. So over to you, Dr. Prasad, to introduce the speaker and invite the speaker for the presentation.
Thank you, sir, for giving me the opportunity. And Next speaker is already sir mentioned about Dr. Surobhi Chatterjee. She is a young medical graduate and she is doing her post-graduation at All India Institute of Medical Sciences, Andhra Pradesh. And she completed her uh, undergraduation from King George Medical University. And she published so many reputed articles in the reputed journals like Lancet and Global Psychiatry, renowned journal. She has more than 30 publications to her credit, and she presented con- at various conferences at national level as well as international conferences. And I can say that she can be the inspiration for many of young scholars or young graduates, those who are attending here. And I'm happy to invite her to present. This topic is very useful, and this is the need of the hour. And AI used by medical students in Indian perspective. I welcome Dr. Surobhi Chatterjee for the presentation.
Hello, am I audible?
Yeah.
Thank you so much, sir, for such a wonderful introduction. So now I'll be presenting my slides. Is my slide visible?
Yes.
Yes, yes, visible.
Hello, everybody. I am Dr. Surobhi Chatterjee, and as sir mentioned, I'm a resident in training and doing my MD Psychiatry training currently from AIIMS, Andhra Pradesh. So the topic for today's presentation is artificial intelligence used by medical student, and I'll be describing both Indian as well as a global perspective on understanding the power and the potential of artificial intelligence and what it holds for our future. So first, disclosure that whatever I have, this presentation actually has used AI, and for that I have already put a disclosure before here. So one of the things that I'll also be covering is that it's important that whenever you are using AI, you're also covering the disclosure portion. So first we'll begin with understanding what is artificial intelligence. So artificial intelligence is basically utilizing the way human intelligence works and combining it and training the machines which are used, particularly the computer systems, so that they are able to perform complex tasks that would usually require the reasoning, the logical ability, and the problem solving, which is usually we call humans for. So there are several uses of it. One of the most useful forms that we are all using these days is generative AI, and I'll explain how generative AI has developed over a period of time, which includes decision-making algorithms, chatbots. There is patient and care systems which are used across the globe now, which conglomerates all the data which is used for patient care. There are digital assistants as well, and medical students are using it for every bit and now for using, may it be their thesis work, may it be their simply writing something, searching topics, so on and so forth. So first we'll focus on how did these AI actually develop over a period of time. So in the 1950s, during the time of Alan Turing, when he first said that what if we can make machines that can actually think? So beginning from that concept, wherein initially there was data sets that was given and simple tasks like, for example, playing chess, and on a rigorous task, which is a uniform based task, if it was given to the machines, they could do that. From that, we have gradually developed to learning deep learning system, which is based on the neuronal function of how human works. And now 2016, when Google first launched its AlphaGo program, to now, as we all know, the launch of ChatGPT and the generative AI. So AI in medical education is basically described in these three formats. So first is about the learner-oriented AI, where we actually focus about the medical students, the trainees, the postgraduate trainees across who learn and use AI to receive and understand the new information. Then AI can also be used by instructor themselves for improving and enhancing the level of discussions they are doing, for gaining new knowledge and improving their presentations, and also for checking and tasks which are more rigorous. Later on, there is something called as institution-oriented AI, which is basically focused upon administrative work and how the patient care could be improvised, how the inventory management could be done, and how the data could be secured in a much easier format. So now, as I told you, I'll be describing how artificial intelligence initially started. So if you can look in the here. So first, it was basically machine learning. So in machine learning, what happens is we first allow the systems to learn the patterns. So say, for example, if you have to learn between machine learning is described in the form of supervised and unsupervised learning. So what a supervised learning actually means is that, say, for example, you have to train a machine system on the basis of how to differentiate a data set. I'll give an easy example and then we'll proceed it to psychiatry. So if you have to ask a machine to train on the basis of identifying images, if an image is of a cat or a dog, so on the basis of facial features, on the basis of their whiskers, the eyes, the kind of eyebrow, the kind of ears they have, those are the different differential features that the machine will recognize, and each of them will be extracted as a data point. Later on, this same data will be used, and that is called as the baseline data or the ground level data. On the basis of that, the AI learns how to differentiate. Now, an AI is as good as the data that you give in. That is why the concept of GIGO or garbage in, garbage out, which means as rigorous and as well validated data that you use across different setups. On the basis of that only, your machine will be able to learn and recognize it and then give a correct output. Next is the deep learning system. So deep learning system actually recognizes the neural networks and the neural framework that humans also use. So for example, there is first baseline data, then there is hidden neural networks, and then the final output. And finally, we came to natural language or large language models, which we now use in the form of generative AI. So generative, the term means that now the AI can learn through the natural language which humans use. So it's validated across several languages. You can use it in an easy conversational tone, and it will generate something for you. Maybe in the form of some text, some images, some video content, some code-based content, based on already validated and pre-trained data that it has been used. And the most common examples that we use these days is ChatGPT or Google Bard system. So this is what the supervised and the unsupervised learning that I was explaining just before this is. So on the basis of supervised learning, this is how our data will actually differentiate. So say, for example, if now you have to provide the same data and move it to psychiatry, if you have to understand what are the certain features or certain markers that can help us differentiate if some person has psychosis or not. So all those differential elements, be it from their cardiovascular to their neurobiological markers, each of them will be trained on a different set point. And this is what the AI will learn. So that is why whenever, even in generative AI, a person giving us a person requiring same answers, when different students put in different queries, the answers which are generated are very variable, because the AI also learns on the basis of the previous questions and the previous kind of information that you have fed into the system. And this is how the system of deep network works. And I'll be explaining why it is important to understand this so that you can understand what are the pitfalls or the drawbacks of AI. So this is deep learning model. So similar to our neurons, this is the input layer, and there are several hidden layers through which the data is generated and is cross-connected. And then finally, all those individual global data points are pooled and given into a concentrated layer. Now what happens is sometimes we cannot go back and identify how did the information actually come in place. And sometimes, especially both using generative and deep AI, we cannot understand why the system has predicted that one person can have, say, for example, psychosis, another person cannot. And that is what leads to the black box phenomenon. So now, what are the real world applications of the AI? So what does the actual data says? So this is one of the studies which was done in 2022 by Chen et al. And he did across physicians and medical students. And he found that in the future, most of the respondents, around 60% of the respondents in the 10 different studies that they included, they were willing to incorporate AI in some of the other forms. So we can see that the future actually encompasses AI, and it's AI in the future. If we don't use it, we are bound to we'll perish if we don't use it. So we see that most of the respondents, and one of the startling finding was that most of the people from low middle income countries were more willing to use AI in their clinical practice because of the hectic workload that they are facing or the less amount of resources that has been allocated, because AI is making their work very easy. And because one of the findings of the study also said that as most of us are worried that will AI ever replace humans. So in this study also 68% people agreed that physicians will not be replaced by AI in the future, and it still requires, AI will still require physician autonomy. Even in branches like radiology, where it was said that AI would completely replicate and would completely, physicians will go out of use. It's said that because AI can generate a lot of faulty data, so it's very important to be cross-validated, and physicians will always be important. So what are the different uses in which clinicians can use it, for example? So in generating evidence-based medicine, to understand what are the different kinds of evidence that is being generated, keeping ourselves abreast upon it, for creating personalized medicine targeted to a group of people, and for patient data and inventory management. For patients, they can use AI for making informed decisions, even in the aspect of preventive healthcare. There's a lot of AI now being developed for community services, wherein, because now it uses large language models, through easy languages, people are able to understand and prevent. So one of it was also successfully developed in Africa, where they prevented the spread of malaria in certain parts. So again, then we saw that among medical and physicians, 65% had awareness on what basis they can use AI for, but most of the knowledge they also felt was more superficial. They lacked deeper insight into how AI works. Around 10 to 30% had already been using clinical AI in some forms, and though it's usually said that medical students, but there has also been a significant uptake of AI by physicians, and sometimes more than that of medical students. In Indian context, when the study was searched, it shows that there was a higher usage in Indian context as compared to a global average. More than 60% of the mental health professionals in our country have agreed to using AI in some forms, maybe for generating answers to their clinical questions, for using it for finding research questions, or for simply providing patient instructions. So the next form of use belongs to it, the research. So AI has been used for doing literature review. You can go through several papers and generate network maps. You can use it to generate questions, for hypothesis, and for simple works like low-level works like editing or validating, or even using it for creating your data sets. And in education, as we know that there is transformative use of AI that is being done now. People are using it for chatbot assistance, so that especially in higher level education after 10th and 12th, people are using it to answer questions related to the fields of science and STEM branches. So now these are some of the examples that I have included. So why are we using artificial intelligence? So first of all is it increases the efficiency. So especially in repetitive tasks, though we say that human mind and everything is derived from it, but we tend to slow down when there's something which is being done repetitively. But that's the benefit with artificial intelligence and machine, that they usually don't tire up easily, and they reduce the time which is taken to generate something. So say, for example, this is one of the example called as mind grasp. Here, whatever lectures that somebody is giving you, maybe it on a video format or live lectures, you can have it recorded. It will transcribe everything for you. It will create small, and if you give all that transcript material to it, it will generate quiz for you, flashcards, notes for you, so that you can use it in your studies. Another example is GoBoat, which is a free to install app. It also creates similar things, quiz on the basis of the materials that you have learned. The second important thing is AI reduces human error. So if we see generally, if humans tend to do things multiple times, that I already said, they get exhausted and there's chances of human error. Now going back and manually doing all that work again is very time tasking, and it's not that time efficient as well. So herein what AI can be used in order to check and supervise and recheck and edit the data. And third, for automating whatever repetitive task is there. Then one of this AI system is called the Genie AI, which also I have used for the presentation, wherein you can understand, you can summarize whatever research papers you are doing. It will help you organize the research. It will help you find similar research data that you can use.
We stopped.
Hello,
Dr.
is it
Surobhi?
visible now?
Yeah.
Okay.
Yeah, you can continue.
Yeah, okay. So next is we saw that how now we come to the Indian perspective and how medical students have been using it. So there are several studies which are done in this regard. One of the studies which was published by Nadia Ahmed et al. On a cross-sectional study done in Jharkhand, where she explored how medical students in India were using artificial intelligence. She found that 80% of the students felt that some kind of bias would actually reduce, and while they do the work, there is more bias in the writings and the answers that they are producing. But on the other hand, they felt that whatever assignments they were given to them, they only had superficial knowledge of it because they were using AI to answer them. So another point that found was that AI training and self-assessed knowledge. Most of them were using AI to answer questions in their assignments, in their homeworks, also in exams at times. So they felt that it was important to understand that even exams like this, even generative AI could generate very faulty answers, and which was not understood by them. The other point that came out by another study by Preeta Jackson et al. Was that AI training in the self-assessed knowledge. Around 91.4% medical students said that even though they used AI, they had no formal training. So they didn't understand that what were the repercussions of using AI, both in their curriculum as well as in their research. Even 35% said that now, because AI is playing a very prominent role, it could also influence the specialty that they are going to take in future. The next point was about competence and confidentiality. Around 26.8% felt that they were competent enough to be informed about AI. And most of them, around half of them, were unsure that if by using AI they are protecting patient confidentiality or not. Most of them agreed that AI actually helps in reducing errors in the medical practice, and it makes them more well informed about accurate decision making. Instead of going through several textbooks to find the answer, they could find all of them and find an answer which is generated, and then they could cross validate it. There's another study which was done which found that, especially in America, and American Association of Medical Students has also called for it, that it is a very high need that there is curriculum inclusion of AI in our studies, so that medical students are also abreast upon what are the different things that they can use, and more so than that, they understand the disadvantages while using AI. Because most of the curriculum across globe lacks such support, especially in low middle income countries. So around 75% of people have supported that there should be structured AI training in medical education. So what is India's medical landscape and what is the AI being used these days? So if we come to India, AIIMS, KMC Manipal, JIPMER, these all institutes of national importance and KMC Manipal have come together and built and used Microsoft actually to create an Elsevier to build virtual cadaveric dissection labs. So they can actually go inside, they can actually visualize each part of the heart, how it works. For example, they can see the blood vessels, they can see everything in a 3D orientation, and the dynamic working of the body could be understood better. So it also reduces the need for the bodies that are required for cadaveric dissection. As of now, both of them are going simultaneously in some of these institutions, and some of them have completely shifted to virtual cadaver for anatomy discussions. Then there is AI patient avatars and VR sets, which are actually being used for simulating psychiatric cases. So they are role play modules which are given for people who are having panic disorder, for patients with phobia. They are used and they are placed on patients, and they have shown significant response after using these AI systems, both in Apollo and KMC. There are also virtual reality surgery modules which are coming up, wherein for teaching surgical training to residents as well as for medical students, especially suturing techniques and all, they are now using VR surgery modules, so which replicates a very true feeling of the materials, and the person actually feels that they are in the heated set of an OR without actually going in an operation theater, and they can see the functioning there. There is also, as I mentioned, significant use of chatbot now in community medicine, and JIPMER has come up with a pilot project on it. AIIMS Delhi has started several radiology modules along with that, and on 10th September, it launched this Never Alone app that you can see here in collaboration with one of its alumnus, Dr. Deepak Chopra, which is an AI-driven app which will now provide 24/7 screening, counseling, intervention, and follow-up for students who are coping with stress and who are having suicidal ideation. So now, what is the global medical landscape as for AI? In India, as we are seeing, there's not any dedicated AI learning that is being developed. There is one of the few projects which are still in pipeline. One of them is like between KG and IIT Kanpur, where they are thinking about creating and including AI in their innovation landscape. But what globally we are seeing is institutes like Harvard Medical School have already started a dedicated semester in which they have a dedicated AI-centered curriculum in the first semester itself of medical students, so they can learn the basics of AI and what are the pitfalls of using it, how to use it. And there is also supervised training method. There is an MD PhD that you can get called as AI in medicine, and a different PhD track is also created. There's some free CMEs also, like AI in family medicine, which is being given. Stanford has started his 100% online artificial intelligence in healthcare program that can be taken. There is University of Illinois, again, which has started certificate course, which again helps in understanding how AI could be used, how we can generate new chatbots, new machine learning tools in the future, which will integrate both the working and the capability and the understanding of physicians use, and will be more data driven. So evidence-based medicine as well as the physician autonomy could be increased further using these chatbots. And similar, there are certain chatbots which are coming up by the University of Lancashire using their specific course using artificial intelligence in healthcare. So some of these tools I have covered, which I have also used, and they are used by several medical students across the globe. So there are some of them which are free tools and some of them which has free and subscription-based services. So say, for example, I'll just cover briefly a few of them. So there's a very famous tool called as Anki, which is already very popular in people who usually pursue exams in US. For them, it's basically a flashcard-based tool. Now it also is coming with the AI bot, which can be included. And similarly, by giving it all the materials and the transcripts, instead of you generating flashcards, it would generate flashcards for you. Similarly, a free tool is Heuristica, which could be used for the similar thing. Concept maps could be included. Medical students can help integrate what we are also trying through the now vertical integration and the horizontal integration of the subjects. Similarly, there is something called as AI Blaze, which could be used for homework. There is MindGrasp, similar for using lecture recordings, scanning all the textbooks and generating summaries. And then there is something called as Unriddle, which can help you write in papers and simplify complicated texts. There are also some of the tools which is indigenously built in India now. Say, for example, Q.ai has helped provide medical imaging interpretation. So students can upload chest x-rays, CT scans, MRIs, and a brief interpretation of the same will be given through these apps. One of the very famous apps before there was the coaching industry and there was so much upheaval of the online coaching platforms, there was something called as Daily Rounds, wherein free case-based learning was provided to medical students and they could upload case and they would be provided with answers for it. Similarly, there's very good tools like Imbibe and MyUpchar, which is for patient content, wherein they can put in information regarding any language and they'll get the answer. These are some of the more tools which they can use. But what is more important to understand is the pitfalls of the artificial intelligence. So these are some of the examples. Say, for example, in MIT, they have recently started that they retracted one of their papers on artificial intelligence because it was completely written by using artificial intelligence by a doctoral student. There's a recent study where Vietnamese students, it was felt that most of them were using it for using ChatGPT. They were using it for their assignments. Even there's several papers. Springer has recently retracted because there was AI generated content in it and they could find exact chats which were quoted by ChatGPT in those published papers. Similarly, in other countries as well, we can see that senior academics were also investigated on their texts being written by ChatGPT, and several preprints included, and there were several papers that had to be retracted because of it. So there's 4 important pitfalls when we come to artificial intelligence. One, as I said, that how the data is generated, it is very difficult to understand it. So there is opacity, data privacy, there is issue, reliability is one of the issues, and fairness, so that we can understand that it is not excluding certain set of data. There's something which is called a pseudo generation or AI hallucination, which most of the students are not aware of. So sometimes when you give prompts to AI, it will give you answers on the basis of the question that you have generated. But when you go back and cross-validate those papers or those text materials, they are actually non-existent. So that is something which is called a pseudo generation. And the black box nature of AI is, as I explained, you cannot understand how the data was generated or how that faulty assumption was made at the initial place. Third is there's plagiarism and people are using that intact AI text. They are not even and using papers. They are plagiarizing the entire data and using it in publishing their own work. By using AI, they are severely compromising the research integrity. So ICMR has come up, I have put it in last. Basically, ICMR has come up with so many guiding principles that could be used in order for that accountability and data privacy rules. And for guiding, it's basically a 27 pages long document where they have included what are the recommendations and how we can include it. So this is the entire ethical checklist that they have put forward that should be followed by everybody who is doing biomedical research and healthcare. And one of the new terms they have included is right to be forgotten, so that a person, if they want, their data should be completely removed from the patient care data if they want it, which should be a right that should be provided to the patients. Similarly, again, this is again a 12 pages document by the American Association of Medical Education, who have come with curricular recommendations of how different sets of curriculum can be included, what is the foundation for it, how the benefits can be explained, how the 4 V's of big data, the volume, variety, velocity, and the veracity of the data should be explained. And it has come up with like 14 modules of how each of these modules could be included in the studies. So finally, I would end my presentation by saying that AI is definitely growing and there'll be wider integration of AI. So it is supposed to grow further and grow very fast. And so it's important that there is closer collaboration. And finally, there is curriculum inclusion. You can use this to read all the papers that I have quoted for further reading. Thank you.
Thank you, Dr. Surabhi, for a nice presentation. And she presented even global scenario as well as Indian scenario and the major chatbots used in India in medical education. And anyway, AI cannot replace human beings, but but definitely it enhances the quality of medical education, clinician, teaching in all the aspects. That is the take-home message. But right now, even if anyone from the audience having any questions, can ask the questions to the presenter. If there is any question, please ask quick because we are running behind time.
Yeah, maybe you can ask. So what, let's say it that way, we are just very difficult path. And I think if we said, since maybe less than 10 years, AI has changed an awful lot. So what's going to have to be, what would you predict in medicine happening in 10, 20 years? So will there be another complete change of AI? So how can you have a look at in the future?
Thank you, Dr. Reina, for your question. I definitely think that there will be wider integration in both curriculum, because now, as even American institutes and even Indian institutes are putting forward, maybe it will be made a different pathway altogether. We can use AI, and instead of blaming AI, maybe we can work in joint collaboration with it. Especially, we are seeing so many research papers where now it's been being mandatory to declare the use of generative AI. So similarly, there should be more methods that should come forward wherein people can tell if they've actually used AI or not. And I think that is the way forward. And clinicians, they should be more updated about AI, as well as they should be more ready to use it, because there's a lot of resistance, especially in people from previous generations, to use it. And so I think using both of these will help.
Can I just say from my experience as an editor of Global Psychiatry Archives, we get more and more papers which are AI generated, where the methods are more or less from the quality of a magister paper or an MD paper, but so it's very often that the statistics is over-explained and overused. And I think that's a worry at the moment for me as an editor. Do you want to comment on that?
Yeah, sure. Because as I mentioned also, there's several papers now. They have shown that around 20,000 papers every year are written using AI, and the level is very variable. Especially like you mentioned, so many words that they are actually using. They are being repeatedly used. For example, statistics or deepen, delve. Terms like this that AI tends to use a lot, and sometimes the content that will be generated will be so difficult to understand that both the authors, the editors are at a fix to understand. And I think that's why also plagiarism tools are coming up, which have also included an AI driven tasks like papers like in Turnitin, you can find how much is the plagiarism. But as that are coming up, even people are surpassing that and using other tools to catch up with this AI tool. So I think that's why we, as researchers, people who are editors of the paper like you, we need to develop frameworks and stronger check tasks. It is our task to like put a check hold on all of these methods that they are using, maybe by using better technologies. And that's why it's important that we work in close collaborations with people maybe from the data scientists area as well.
Okay.
Definitely, there are challenges, as Professor Rana mentioned. Yeah. Any other questions?
I can see one question here by Dr. Ipsita, who has asked, could you please guide us as to how to choose which AI platforms we should use and how to ensure reliability? So, as I mentioned, that it's not just about the tool that you're using. Some of the tools I have mentioned in my presentations, but all the AI tools, irrespective of whether they are free, they are subscription based, whatever tool, they have this tendency. They can still be that they're generating the data that they're generating is faulty. So it's always and always that I tell to everybody that whatever papers you're citing, even using ChatGPT, go back, search that same paper. Is it available, say, for example, on PubMed? Is it available on Google Scholar? Because so many times they hallucinate, they create authors which are non-existent, or authors who are not in that field only, and those papers are generated. So I would say that it is, again, it's our responsibility and our duty as a researcher to cross-check and validate before we present the data and use that data anywhere else. So it's not that one tool can help you.
Thank you, Dr. Surabhi. And if there are no questions, then we can hand over to Professor Rana and Dr. Sujit.
It's Sujit coming up now. I don't know who would introduce the next meeting. Sujit, are you still? I don't know.
Yeah.
I think.
Good evening, all. Now it is the time for the symposium. Symposium title is War and Mental Health. This symposium will be delivered by Dr. Vipul Janardan, Dr. Gaurav Uppal, and Dr. Anusa Garg. Dr. Vipul Janardan is a psychiatrist at Institute of Human Behavior and Allied Sciences, New Delhi. His core area of interest is sexual medicine, gender and transgender mental health, AI and psychiatry, social psychiatry. So broad areas of interest. He has several publications to his credit, and he is an active member of Global Psychiatric Association. Along with him, there is another person who is Dr. Gaurav Uppal, who is a gold medal winner in the postgraduate psychiatry examination from Manipal University. He is a consultant psychiatrist. He will also be the second speaker of the symposium. And the third speaker of the symposium is Dr. Anusa Garg. I believe Dr. Anusa Garg is also available here. So Dr. Vipul Janardan will be basically moderating the session, and he will be the speaker and he's coordinating this session. Over to you, Dr. Vipul, for the presentation. Maybe we can finish the presentation in 30 to 35 minutes by all the three speakers, then we can take a question answer.
I think because of some reason, Dr. Anusha cannot be, she cannot present here. So we will be speaking.
Yeah, you can finish the presentation in 30 minutes, 15 minutes for each of the speaker.
Yeah, we'll try to do it as fast as we can. And so this is my our presentation, War and Mental Health. I'm presenting along with Dr. Gaurav Uppal. So when we think of war, most of us pictures ruined, building collapse, infrastructure, or injured body. But what often goes unseen are the psychological wounds that can last for longer than the physical scars. War affects not only soldiers on the frontiers, but also the civilian, children, and those forced to flee from their homes. And yet, mental health is often overlooked as a part of the emergency responses. Researchers show that long after fighting, ants communities continue to struggle with depression, PTSD, and the other psychiatric disorders. In fact, as Steele and colleagues highlighted in the landmark JAMA paper, post conflict trauma leaves a profound long term impact. So, when we talk about war and conflict, it is easy to focus on politics, borders, but the real impact is felt by the civilians. Imagine losing not just your home, but your family and the sense of safety overnight. That's the reality of millions. Constant exposure for violence, to torture, or even starvation leaves invisible wounds, increase the risk of depression, anxiety, and PTSD, and the overwhelming grief. And it's not just numbers. Behind every statistics is a child robbed by childhood, a woman facing heightened by vulnerability, and the family shattered. These are not short-term crises, they are trauma that echo for the generation. That is why mental health support for civilian in conflict isn't optional, it's essential. So when soldier returns from a battlefield, the war doesn't end for them. It simply shifts inside. Many face combat, stress reaction, moral injury, and post-traumatic stress disorder. But the tragedy is that the stigma often keeps them from seeking help, as if admitting distress somehow diminishes their services. Studies like Hodge and colleagues in the New England Journal of Medicine show how common these struggles are, yet how rarely soldiers reach out. Suicide rates are often climbs after the deployment, reflection just how deep the invisible wounds can be. Yet, yet even when they come home, reintegration into society is not easy thing. Many ways the battle after war can be just as tough as the one in the frontiers. When we think of war, most of us picture most of ruined buildings, most of things ruined building, collapsed infrastructure, or injured body. When the refugees carry with them not just a suitcase, but layer of trauma. Many have witnessed violence, lost family, and the endures harrowing journeys into the survivor. Yet, when they finally reach refugee camp, safety and the psychiatric care often missing. Studies like Fizzles and colleagues, the Lancet reveals shockingly high rate of depression, even in the psychosis among displaced population. Beyond the clinical picture, like something deeper, the pain of the cultural loss and the identity crisis, where people feel cut off from their roots and the community. In other words, the refugee crisis is not about the border or shelter. It's about broken identity and fragile minds. And the depression at the time they need support. Similarly, children in the conflict zone, imagine being just 10 or 12-year-old and instead of sitting in classroom, you are handed a weapon. This is the tragic reality of the thousand children recruited as a soldier in conflict zones around the world. Their childhood is stolen, school disrupted, and the innocence shattered by the violence. Many suffer developmental trauma, not just when they have seen, but from they have been forced to do. They often return home with the deep psychological scars, nightmares. They won't let them sleep, sudden outburst, emotional numbness, and the hunting inability to connect with others. These are not just temporary issues left undressed. They can evolve into serious long-term condition, conduct disorder, depression, and the PTSD. As the Betancourt and colleagues powerfully noted in Java, these children are not just victims of wars; they are survivors, profound emotional injury, and they deserve them our sympathy, empathy. They need structured psychosocial support, educational reintegration, and above all, hope. So, in many war-torn regions, rape is not just an act of violence; it is a weapon of war. It is used strategically to terrorize community, assert control, and dismantle the social fabric. But the trauma does not even end with the assault. Survivor, often women and girls, face deep social stigma, forced silence, and isolation. Many are blamed instead of supported psychologically. The damage is profound. PTSD, chronic somatic form, stress disorder, anxiety, depression, and there is tragically an increased risk of suicide. Worse still, these atrocities are vast underreported. The shame of fear, lack of accessibility care leave most survivors unheard and untreated. As King et al. Emphasized in the American Journal of Public Health, gender-based violence during war is not only human right violation, it is a public health emergency that continues long after the conflict end. These women don't just rescue; they need long-term trauma informed care and the global shift in how we respond. So coming on to the most important aspect is neurobiological effect. So when we think of war, we often focus on the visible wound, but most of most of the devastating injury are invisible, as deep into the brain. War trauma directly impact the brain's stress response system, is especially the limbic system, HPA axis, the very circuit that regulate emotion, memory, and fear. Even more striking, recent evidence suggests that trauma can trigger epigenetic changes, potentially passing the psychological effect across the generation. This is not just psychological, it's biological. Trauma leaves a fingerprint on the brain itself, reinforcing the urgent need for trauma-informed care, especially in post-conflict mental health programs. When the wounds of the war go beyond the physical, healing must begin from within, and that begins with the trauma informed psychiatric care. Evidence based therapies like CBT, EMDR, and RTMS are showing real promises in treating PTSD, trauma related disorders. Group therapy that can also play a key role, especially for the survivor who feel isolated in their pain. We must go beyond just symptoms. Psychological rehabilitation, resilience building, and the restoring dignity and agency are essential step in the long road to recovery. As emphasized in WHO guidelines, healing from war is not just about survival; it is about restoration, reintegration, and the reclaiming one's future. When the war ends, the rebuilding begins, but the mental health is often left behind. In fact, less than 2% of the global health funding is allocated to mental health, even in the more devastated conflict zones. This must change. Mental health care is not luxury, it's a lifetime. It should be central to the every humanitarian response plan, not often an afterthought. We need to integrate psychiatry into post-conflict rebuilding, from the field of hospital to refugee camps, and ensure that the cultural sensitive trauma informed care is accessible to all. But this only happens through strong sustained advocacy. We need to raise our voice across government, NGOs, and the global health program to save mental health, not just in peacetime but especially when the world is at war. True healing starts when we prioritize the invisible wound just as the visible one. In India, the scars of the conflict are not confined to border. They are right here, from Kashmir to Manipur. Amidst the refugee influx, thousands face ongoing trauma every day. Yet the reality is stark. Underreporting is rampant, and the mental health infrastructure remain stressed, particularly in conflict-affected regions. When it is needed, it's not just more service, but better ones. Service that actually cultural rooted, community informed, and trauma sensitive. Recovery is not cannot be copy pasted from the West. It must the language of the local pain and the local resilience. But lies the opportunity in itself. So in the last war, I just want to say war does not end war. And when the bullet is fired, it's a psychological aftershocks, lingers for the generation. Survivor carry invisible scars, trauma, grief, or loss of identity that demand urgent, sustained mental health support. Psychiatry is luxury in the post-conflict zone. It is a core pillar rebuilding lives and society. We must prioritize trauma-informed, culture-sensitive care, especially in low resource and conflict-affected zone. Thank you so much. Over to Dr. Gaurav Uppal.
Dr. Vipul, you can unshare your screen so that Dr. Vipul can start sharing his screen.
Okay.
Good evening all, and thank you so much for giving me a chance to present here. I'm just share my presentation. Yeah, can everyone see it? My presentation.
Not yet.
Yes, all right. Right. Thank you, sir. Thank you sir, for giving me the chance to present over here. My name is Gaurav, and I'm a psychiatry doctor. And currently, I'm practicing in northern part of the India, in Ludhiana. And I'm also like unlike other people, I couldn't get a chance to go through. I just got the anecdotal evidences, and I just couldn't get the chance to collect a lot of evidence for it. But what I'm going to do is I'm going to explain the situation, what is going on, especially when the war in context of the mental health, and I'm just trying to make some sense out of it. So what happens in war is that, it's like, there's a sudden change in the environment. It's quite easy to start the war, but it's very hard to stop it. And then there's suddenly change in the environment. Whatever was normal is not normal anymore. And war has different, presentations in different groups. Commonly, the war is divided into two the psychological effects of the war is divided into two main groups. The groups with the militia, the army, and then there are civilians who get impacted with the war. And what I'm going to do is I'm just going to take some of the examples, what are going on currently, and then we are trying to make the sense out of it. There are different contexts in which the war is going on. Different situations in which the war is being presented in front of us. For example, India has seen major skirmishes since 2021, since Galwan and Pahalgam was the last one. And Ukraine war, it just started in 2022 and it's going on till now. And then there's Israel and Palestinian war. And even in the Indian war also, I'm just going to explain what are the special things which we saw in Pahalgam, Balakot and Galwan. And then we are also going to understand the role of the psychiatry people and what is the role of a psychological first aid, which is quite important in the war situations, and why everyone, the psychiatrists, the psychologists, and everyone needs to be trained into this kind of, situation. In India, we know that there are two ways in which the wars present. Full-scale wars are rare in India, but generally there are border skirmishes, and then there are insurgency, the proxy wars. But Ukraine just saw the full-scale invasion. It saw trench warfare, massive displacement of population. Palestine, it saw it is seeing a prolonged siege. All right, even people are getting displaced, and there's a war of narratives also which is going on. And it's also the intensity of the combat and the displacement of population, which is all causing a lot of problems. And some of the aspects are related not just to displacement, it's related to the refugee situations and also the ongoing war which is going on. So there are a lot of things which are going on, and even the healthcare system which used to exist before, it doesn't exist anymore, especially when the war is going on. Generally, there are some of the disorders which Dr. Vipul already covered, for example, the PTSD, acute stress reaction, then depression and major depressive disorder, if things get prolonged, anxiety disorders, panic attacks, even the veterans, afterwards, they are not able to overcome that trauma, like Gababate says, and they start taking substances. And people are suffering from adjustment disorder, especially the women. And then there are some emergent phenomena, if some veteran, he loses all his friends, then they develop the survival guilt that leads to suicidal ideation. And then now the ICD-11 also recognizes something which is a complicated form of PTSD, which is complex PTSD, in which the identity also get affected, and the person has emotional dysregulation. And so all these things have been like becoming prominent. Like, for example, like if we saw World War I, people used to have shell shock, all right? And then in the World War II, people started having combat fatigue. Now, like humans have evolved, perhaps the human psyche has evolved. So we are suffering more of PTSD-like situation. In India, there are some situations, especially in the war-related situations, the wars are generally fought at higher altitudes. Like, for example, like usually what happens is that usually it's the borders are on Himalayas. And because of that, you know, the Indians, they either they start having the depression because of the temperature, they have sleep disturbances, the Indian soldiers I'm talking about. And then they are like also like they start having the cognitive deficits. And the other thing which we are seeing is like high altitude cerebral edema, HACE, which is also seen in the Indian population. And then the people out of the influence of that, they also start hallucinating. Like sometimes they also see things which other people do not see. And that's called as like third person phenomenon, which we are seeing in the Indian soldiers. Again, this all is anecdotal. I've just got from some news articles. I was not able to back up these all things, but I just got this information. And then in India, also like it's hard to get care because like still people have like they stigmatize the mental health. And even the war also the trauma also gets complex because like, you know, it's not just survival guilt because of which the people commit suicide, or perhaps they're not able to adjust to the civilian life. Sometimes there's also the fratricide rate is also quite high. A fratricide rate also affects the war. For example, like the people die in the friendly fires. That again, like, you know, complicates the trauma which the person is suffering from. All right. And then like, you know, there's also like a transgenerational trauma about which Dr. Vipul talked about. I'm going to talk to you about that's about the displaced population, not the people we are suffering from the war, the soldiers, right? Like, let's just take about the situation about Pahalgam attack. What happened was like people went there in Pahalgam and, you know, there was suddenly an attack and then like, you know, they killed the men. And then after that, like, you know, the families were devastated, especially the women and children. So they were like, initially they had that shock. And after that, they had survivor's guilt. And then, you know, even like they were numb in the beginning. And like even like there were instances like when children had bedwetting, they had, you know, mutism. All right. So all these things they manifested themselves in Pahalgam attack, which just happened. Although the government, you know, they put the thing like it led to a major war at the other side as well. But the thing is like damage is already done. And then there's like the Balakot airstrike, which happened in 2019. And again, like I'm not talking about the politics of it, but I'm talking about the things which soldiers suffered from, and I'm just talking about the phenomena what they suffered from. Like one of the things was like there's something called as combat readiness syndrome. All right, like it's a kind of like, you know, a kind of again a thing which is used in the news jargon, in the news articles and everything. Like people are, you know, they are always ready for the fight. So that's the combat readiness syndrome. And what about the people who are watching the news? They suffer from something which is called the civilians. They suffer from something which is called as vicarious trauma. What happens is that if there's a news, the negative news which keeps on, you know, getting broadcast in front of you, you're always, you know, you're always scared of it. So that's called as vicarious trauma. And then like, you know, there are some of the things which are like there in the population which is going on. All right, because of the war. And then there was another war which India saw at the time of COVID, and that was Galwan clash. And like there were like, you know, the civilians who died, and because of that, they suffered from the hypervigilance syndrome and even like high altitude related war effects they could see. And even like people also develop some another special syndrome which is called as barrack syndrome. Now, what is this barrack syndrome? Is like when you stay in your barrack for a long period of time and you do not interact with the other people. So like you're isolated and like you have those effects in your body for a long period of time, in your mind for a long period of time. So again, that thing which was seen in the Galwan clash, right? So I'm just like talking about some of the wars and just comparing them. like the Indian wars, like the Balakot, Galwan, Manipur, everything, and Ukraine war and Palestinian war. The wars, the Indian, like, the skirmishes, they just came and then they went back. So they usually just led to PTSD, stress reaction, depression, survivor's guilt, and so on. But Ukraine war, it's something which is going on. And Palestinian war has led to displacement. And it's not just going to lead to displacement, it is also going to lead to a transgenerational trauma, which is going to get passed into the generations. All right. India does have some of the things, like they have like the military psychiatry units, AFMC, even the telepsychiatry aid is available, NIMHANS is available, but other countries, they are actually kind of losing their infrastructure. All right. So this is something which is going on in India. So generally, like I've just discussed about like the difference between the different situations, the different wars, and then there are also children-related trauma. Like for example, the children, they develop this kind of attachment disorders, all right, in the beginning, and then adolescents, they have problems in the school, and people in like when they are in their teenage, they have difficulty in forming relationships with someone else because they're so distraught. And then there's something which is also called as transgenerational trauma, which is often seen in the Jews, and now in India also in context of Kashmiri Pandits. So what they do is like, like first of all, the trauma, it has the epigenetic effect. And after that, when the trauma gets passed into the next generation, like they might not be as normal as jovial like you are. And they also might start suffering from some kind of psychological illness, or perhaps they're more vulnerable. All right. So that's something which is a transgenerational trauma. And it requires long debriefing, long, like, the cognitive behavior therapy. The things which have happened in the past, obviously you can use EMDR, but these kind of things, they require the trauma debriefings and so on for a long period of time. Then the skill which everyone, perhaps like everyone should know, is a psychological first aid. Like, for example, like if a situation happens when someone has just faced the trauma and is in a state of shock, what you need to do, all right? You need to have those skills. So what are these skills? Like the person might present with shaking hands, rapid breathing, tearfulness, and they might have concerns about the family and they don't know whether the families exist or not. All right. So what you need to do is, like, first of all, you need to calm the person down. All right. You get that person engaged with whatever the help is available, provide the safety and comfort, stabilize the person. All right. Get the information, whatever is available. All right. Don't give too many hopes, but just try to give the information which is available. You try to link to the social supports which are available, even if like someone has a cultural understanding, Hinduism or Islam or Christianity or whatever, you can just tell the people, give them the beliefs which give them comfort. Because like that time, it's not like you don't have the insight, all right, and you can do things which are not under your control. So these are some of the things which might, affect yourself during the time of which you might have to do, like for the time the person gets stabilized, and then you get them connected to the services, so that they go through the stages of the stages of perhaps like meeting their loved one or stage of the grief, but they get the time to process it. All right. So and it's not like that. The therapies and the debriefing, and they need to talk for a long period of time. So these kind of things, they actually work. And even nowadays, like people are also using the ketamine treatment because like that, that helps in processing the trauma. And so that also helps in, like reducing the effect of the trauma if you combine it with psychodynamic psychotherapy. So it's important that we need to know about how to handle these kind of situations, but we also need to get prepared about all these things. So, well, thank you so much for listening to me, and thank you so much for giving this chance to me. Thank you so much, Sujit sir, and thank you so much, Dr. Rain.
Thank you so much, Dr. Gaurav. Thank you so much, Dr. Vipul, for the interesting presentation. This is something very important that everybody can relate to it. Now, if you see the global scenario, the most of the countries, they are either directly affected by war or indirectly affected by war. So it is almost every corner of the world is affected by the consequences of the war. So I will invite any questions from the audience. You can put your comments or questions directly in the drop box, in the chat box, or you can directly raise your hands and you can ask the question.
Can I ask, yeah, so may I ask, just give me a second.
Yeah.
The question is, I think this Gaza war or the Palestine war is very special. And, I think the world has never seen anything like that. I think we have seen whatever different types of wars, but I think it's like a war of whatever against one country and against civilians. And so I think it's quite unusual in the way. And I don't know, you mentioned the future, how will they manage something like that? And I think we had this Halabja discussion yesterday. And so the question is, why is it so difficult, and why is it so special, and why is it that people who had possibly more or less the same experience from the Germans and do something different or do something similar?
So I think it's different because because they don't have the home anymore, because they don't have anything to turn back to. So one of the things is that, and it's very hard because although you might criticize your country, you might criticize your home so many times, but if you don't have a home, that generation can never process that trauma itself. And the Jews have been experiencing that, and they are not able to overcome that for a long period of time, and perhaps they will never overcome that, and they might lead to some kind of these permanent scars on them. I know it's I wish that there was a hope for this, but I wish that things became all right, but that's just a wishful thinking.
And it is also very
I think
difficult.
it's a good question, sharp and important. Short version, like in Halaba, and there is the use of the chemical agents and the state organized mass targeting was done. So probably it was taken to a much longer period of time than the other wars. So probably it is different from that. It could be the reason.
Any other questions?
Yeah. I'm looking at it from the root cause, religious, spiritual angle. What can we do about that going forward? That would be my question. Otherwise, this war may continue forever.
Like spiritual during the time of therapy, post-war therapy, and during the time of therapy, that we can use the use of the spirituality in the during the therapy, then it can be helpful because it renders hope and also optimism in the person, and in the nature of in the energetic context, they can tell about all these in the energy realms, and they can elaborate all these things in terms of God and other things, like if whatever the knowledge and whatever the experience they are having during the war, they can during the time of therapy, then they can explain all these things in terms of spirituality or religious thing. I think
The thing is you have to have the cultural understanding, but the most important thing, which I think is try to make people comfortable first. And why these wars do occur, it's perhaps the human nature. All right, first of all, there was people used to people were bored of dictatorial regime, autocratic regime. They wanted democracy. Then they again they fought against the dictatorial regime and they went into democracy. Now again, like people are bored of democracy, and they want to go back into the dictatorial regime, because like currently all the leaders all around the world, they're all, they are almost like autocratic kind of people. So this is the situation the world is in right now. And again, like this, like it's like human nature, like like perhaps like everybody wants to like make sure that they lead the world, and it's the fight for supremacy. It's not about religion, it's just somehow like human nature. And but the thing is, like, it's colored by these weapons and everything. It's all going on, and that's why like these all they generally, like, for example, I just give you an example, sir, if I may, just in 1 minute. Like, for example, like when there was there was like this all started after COVID. What was COVID basically? It was a imbalancing act of the power. Like before that, like the Western world used to be superior and the Eastern world used to listen to the Western world. And when there was COVID, there was shift in the power. And to rebalance that power, everything started. Even before that also, like when there were other pandemics also, like SARS virus and all. That happened, there was again the imbalance in the power. And again, people wanted to preserve their power. And in this act of preserving power, there was a war. So it always happens, like, like perhaps when they learn that how to coexist with nature, till that thing does not prevail into the senses, these things will keep on happening. So that's something which seems to be logical to me.
I think Dr. Param is pioneer in the field of spiritualism in psychiatry. So he can tell best how can we help the war victims and the soldiers and the poor, like the women and like refugees. How can we help in terms of spiritual context?
Yeah, thank you, Vipul. Vipul and I we have been collaborating a lot. Thing is, in a given moment, after the suffering has happened, after the injuries, I don't have anything for that. We have all those things which are existing in the current world, treatment for PTSDs and various and sociological supports and all for those who have lost homes and things like that. But I'm thinking of as a prevention of a next layer of war, next episode of a war. There has been episodes of war in between Palestine and Israel ever since it came up in 1947. It's not post-COVID, Gaurav. The thing is, what we need to do, there's the war between Israel and Palestine is primarily religious, spiritual. It's nothing to the fight for land is just superficial. So as we have seen, there will be no. I'm probably going into another area of political discussions, but we cannot escape it. We cannot shrug it under a carpet. The thing is, they are thinking of a two-state theory, but two-state theory will never last long. It will continue just as what we have now between India and Pakistan. It will continue forever. So the reason underneath the two-state theory is differences between you and me, your religion versus me religion. What do we do to solve that problem should be the focus for us. My next presentation is going to be on that. Evidence-based spirituality is needed. That's where I will talk. But as I was listening to you, Gaurav and Vipul, I was thinking that we should probably put together another symposium for ANSIPs. So I just texted Vipul. We'll work on it. And others who are interested, we can join and make something much more powerful. This has to be brought. Thank you. This is a great topic you both brought. I was shocked to see that topic, but I'm now pleasantly surprised. Thank you so much.
Actually, this credit goes to Dr. Sujit Kar. So he has, and Dr. Professor Ryan. So he has asked me to bring something up from. So they are
let's bring both those two people too. Sujit and
they have conceived this idea because when we were doing all these things, so at that time war was going on. So that probably so credit goes to both of them.
Cool.
There are
Thank you.
few more questions in the chat box. Maybe we can take quickly those questions. One is
Sure.
regarding the psychological first aid to the war victims and their family members, and another is with respect to the generational trauma and displacement. There is another question that is interestingly raised by Dr. Surobhi Chatterjee, that is regarding the genocides and uprising recent event like Nepal. Very recently, there is a similar kind of incident that happened in Sri Lanka, subsequently in Myanmar, Sri Lanka, Bangladesh, then Nepal. So a lot of South Asian countries are affected by this uprising and mass killing and political instability, ultimately affecting the mental health of larger public. So not only we are dealing with war and terrorism, we are dealing with other issues which are of similar kind. So do you have any answer to this type of challenges that we are facing right now? How this can be dealt? So briefly, you can answer to this question. Probably this will be the last question. We will be going to the this presentation.
Actually, since we are psychiatrists, we are merely focus on merely focus on the psychotherapy aspects or psychiatric aspects. So dealing with war is difficult thing. It is a more a political issue. So as I have told, trauma focused therapy, debriefing, and other therapy can be helpful in that context, and also like the understanding the social and the economics as well as the cultural context of the country that war is happening, so we can deal with the as per the social context and other things. So but most of the literature when we go through, so they have talked about like in the any kind of psychodynamic psychotherapy like trauma focused therapy that can be helpful during, and debriefing can be done, but debriefing cannot be done in case of children. So these are the things that can be helpful. Along with that, if they needed pharmacotherapy and other therapy, then we can go ahead with that.
Thank you, Dr. Vipul. Here, Professor Renner, we are missing Dr. Daria Ahmed, who is actually working for this war-related victims through his program e-mental health and psychosocial support for the war victims and those who are affected by this kind of disasters. Maybe offline support may not be feasible for all the individuals who actually need the psychosocial support, but an online support can be delivered to remotely. You can provide those services, those who are remotely located and victims. So this is another interesting area.
I think we should consider another symposium on this issue.
Yeah, we can think of that.
We can work on that.
I really invite you for that, because this is what the Global Psychiatric Association is about, trying to support people in other countries and raise awareness, and sadly we have a situation where war is coming into people's lives, and not just via the media, and some people are really suffering a lot. Anyway, I think
thank you so much. We'll be going to the next presentation. This presentation will be a video presentation by Dr. Juan Gaitan, and Professor Dr. S.M. Yasir Arafat will be chairing that session. I invite Dr. Yasir Arafat to introduce the speaker, then Dr. Renner will play the video of that presentation.
Thank you. Hello. Hi, Shujit. Am I audible?
Yeah, you are audible.
Hello, Rainer. Nice to see you after a long time.
Yeah.
So let's move to the business. For his video presentation, Dr. Gaitan graduated from University del Quindo in year 2010, after which he dedicated to primary care and clinical care in mental health environment. In 2016, he graduated as an addiction specialist in University Catalonia Luis Amigo and participated as a speaker and consulted in several specialized addiction services in Colombia. In the same year, he traveled to Argentina to continue his education in psychiatry, while at the same time extending his competence in dementia care. In 2018, he presented his brand new psychological model named Consequence Theory based in classical philosophical framework coupled with cutting-edge neuroscience. Currently, he gives seminars about a psychological model and its clinical application, mainly in addiction medicine. So I request Dr. Reiner to play his video presentation. Reiner, over to you.
Okay, give me a second. Just
Good morning and hello. My name is Juan Gaitan Buitrago. It's a pleasure to be here with colleagues from all over the world. Special thanks to the Global Psychiatric Association for taking me into account to give this presentation. Today I want to share with you some lessons learned from managing a private psychiatric practice, because our work is not only about clinical excellence, but also about building sustainable, well-managed systems that allow us to serve our patients better. Now, why is it important to understand management in psychiatry? Psychiatry is, as we all know, a science of care, but it's also a practice that requires management. Without proper management, even the most brilliant clinician can end up overwhelmed, inefficient, and unable to reach his or her full potential. Understanding management means building a framework that protects our time, our resources, and above all, the experience of our patients. Regrettably, current medical schools all around the world spend way too little time teaching the future doctors about having a sustainable private practice, and this lack of experience and formation extends to the public and private sector with disastrous consequences. Now, let's talk about strategic management. Strategy is the foundation of any successful practice or business. Just as we do not prescribe without a diagnosis, we should not manage any kind of practice or business without a clear direction. A strategic management gives us the compass to move with purpose instead of drifting from day to day. Gives us clear goals, gives us absolute control regarding our finances and our projections for growth. Now, ask yourself, what makes your practice unique? Is it a subspecialty? Is it a therapeutic approach? A style of care that patients remember? Once you define it, project yourself 5 or 10 years ahead. Where do you want to be? Okay? That vision is your mission, and it should guide every decision you make. Because if you do what everyone does, you won't do much at all. This extends to the growth of a clinic or when a private practice requires the employment of more psychiatrists in order to fill up the agenda or to satisfy the demand of the service. And in order to project your growth or the need of more personnel or the location of your practice or the future location of a clinic, you will need to state your mission and visualize where you will be headed in some years ahead. Now, let's talk about key performance indicators. These are a favorite of mine, and I cannot stress enough the importance of having them. Numbers matter. Just as we rely on clinical scales, we need key performance indicators for our practice. We need to check about no-show rates. That's when, for the international spectators of this presentation, it means those patients that schedule an appointment with you, but they do not show at the moment of the appointment. This has disastrous consequences financially and logistically, taking into account that any respectable practice has to start somewhere. And in the beginnings of any private practice, the volume of patients per agenda, it's not that great. So when you are beginning in your private practice and you have, let's say, like you could manage to get 3 patients for one afternoon, because you are beginning, your service, your practice is not very well known. You're just beginning. And one of those patients schedule an appointment and do not show for that appointment, it means you're losing 30% of your daily income. Multiply that for the time you apply for your practice. It's common to have a private practice as a side job when associated with a job in the public sector or the private sector. So in order for you to be successful in your private practice, mostly in the beginning, in first steps of your practice, it will be very important to have a correct grasp of the reason of the no-shows, the quantity of the no-shows. Just to give an example, of course, you need to have a firm grasp of the revenue per hour, the satisfaction of your patients. These are not just business metrics. They are clinical tools that will tell us how accessible, how efficient, and how effective our service really is. Now, the next one is really important. We will talk about proper quarterly planning. Annual planning is not enough. Medicine is dynamic and so are finances. This is why quarterly planning is essential. Set revenue goals, forecast costs, and always compare best case and worst case scenarios. And remember, please, saving for reserves is not optional. It is what keeps your practice stable in uncertain times. I will stress this last topic some more times in this presentation. It's quite important to be prepared for surprises, because as psychiatrists, having a surprise in a case normally has a negative connotation. And also, this is also true for business management. Yes, you need to have a proper understanding of the finances of your business, of your practice. And looking at them once a year, it's terribly risky. Of course, these scenarios I propose are not mandatory, and you need to adapt your forecasts to your capabilities and the nature of your practice. But I would suggest that calculating a best case scenario when 90% of your schedule is occupied, or a worst case scenario when half of the patients attend your schedule, it's a pretty conservative metric in order to do your financial planning. Of course, time is the psychiatrist's most valuable resource. Productivity does not mean longer hours, it means smarter hours. Managing your agenda well is not only a business skill, it's a matter of self-care and professional sustainability. Adding hours doesn't always mean adding patients. Learn about your peak hours, measure your demand, and adapt your agenda. Efficiency is about matching your energy and resources with the real needs of your patients. Regarding this topic about your peak hours, the metrics are quite important in this in this way, because they will help you to understand why patients prefer certain hours. Is it because they are off work hours, or because they are more comfortable in hours that are not so busy with traffic? There are many reasons as patients are, but you will need to have a good grasp of the reason why there are peak hours and value hours, and try to adapt your practice in order to balance the demand in the peak hours with the offering in the value hours. Now, please set standards in your practice. There is something called standard operating procedures. You need to think ahead to when you will not be working alone. Someday, if you are successful, you will need a bigger team: psychologists, social workers, other psychiatrists, administrative personnel in case you grow your private practice in a full-fledged clinic. In this regard, you need to document every process: admissions, billing, follow-ups. The standard operating procedures are not bureaucracy. They are the backbone of continuity. They ensure that your practice will run smoothly, even when the staff changes or when you, while being busy with administrative work, will not be able to attend the minutiae of the day-to-day practice of your future clinic. Now, every minute saved on administration is a minute gained for patient care. This is true for a small private practice, a beginning private practice, or a well-established and traditional practice, or even a huge mental health institute. Help yourself with automation tools for scheduling, reminders, and invoicing. Technology should serve us so we can serve our patients better. In my experience, in my absolutely personal experience, there is a huge difference in having a managed practice and having an automated practice in this regard. I had the fortune of beginning my practice like 6 years ago, and when I began with my practice, this one I was the staff, I was the psychiatrist, I was even the general practitioner, the general physician. I was also the CEO, I was also the accountant of my practice, and trust me, administrative labor is exhausting and takes a lot of time from your daily schedule. So having a software or an application or a platform, a web-based platform, for example, that helps you with billing and helps you with scheduling and reminders of the appointments makes a huge difference in your day-to-day basis. It saved me like 3 or 4 hours of extra work every day. Now, let's talk about finances. We cannot take care of the patients if we cannot take care of our own practice. Financial excellence means distinguishing fixed costs, variable costs, savings, and unnecessary spending. And let me emphasize this. Please stop the non-essential spending. It's important that you have a correct grasp of your budget and your current spending. It's needed to compare what you have planned to spend versus what you have really spent on every month. It makes also a huge difference and lets you take a good look and a specific look to the items that are draining your practice finances. Okay? Savings should be a very sacred, important, and unviolable part of your budget. And it's crucial to include in your savings future expenses like your software, like your insurance, your civil responsibility insurance, and others, or your, I don't know, your AHR. It's important to have good savings and have them precisely discriminated in order to have a correct grasp of your spending. Okay. Please remember this. Peace of mind has a price, and that price is savings. Always keep at least 3 months of operational costs set aside. When you begin with your practice and you have calculated your viability, the viability of your practice, which is a conduct, a practice, or a tradition that most successful business managers follow when planning to start an entrepreneurship or start some kind of business. But doctors are not accustomed to make viability calculations, financial viability to be more precise. If possible, by the time you begin with your private practice, keep in your savings at least 3 months of operational costs set aside. There will be think times, and what you will save today, it's what you protect your practice and your patients tomorrow. Income is irregular. Never trust your gut regarding this. You will have to always be prepared for the worst. Now, become the octopus. What I mean about octopus is that you should take advantage of any kind of opportunity that presents to you regarding sources of income. Just as in biology, diversity is resilience. Consultations, packages, second opinions, alliances, all are ways to create a more robust practice. If one stream fails, other will sustain you. This is really important because you cannot keep your income from just one source in a private practice. Not only regarding the ones that come from a marketing strategy, because once the impact of your marketing strategy wanes, the patients will stop coming. What has worked for me and has worked wonders is to have a solid network of contacts and strategic allies. Offer them discounts, offer them packages, benefits offer them benefits that impact their daily practice, and make sure they take you into account when they need some help with a patient who has mental health needs. Now let's talk about user experience. This is really important. This is a very disregarded topic in medicine. And you should know that a patient's journey starts long before they enter your office. It begins when they find you, how they are welcomed, how payments are handled. This is very important, and how easy it is to return. Every detail of that journey shapes their perception of care, and each step should be properly identified and documented. My advice is that regarding the path of the patient, regarding their user experience, their core user experience, you should manage to set up some key performance indicators. This is really important, and you should pay extra attention and be quite careful when managing this path of the patient. Designing the experience. Psychiatric practice is not just about therapy, it's about creating a healing environment. Consider the five senses. What do the patients see, hear, feel, smell, and taste in your office? Safety, comfort, and attention to detail create a therapeutic experience in themselves. Please do the experiment. Assist to the practice of a colleague, a non-psychiatrist colleague, for any reason at all, and close your eyes in the waiting room. How does it smell? The smell is the first sense that is activated when experiencing a new area. Now, how does it look? Does it look modern? Does it look clean? Is it comfortable when you sit on a chair in the waiting room? Can you see the physician? Does he welcome you properly? Is the assistant, the receptionist or secretary available? Are there refreshments? Even the taste of tea or coffee can shape a proper experience in a psychiatric private practice. Now, feedback is not optional. Positive reviews are always strengthen us, but negative ones transform us. Satisfaction surveys are not about ego, they are about growth. A practice that listens is a practice that evolves. And I want to stress this last, the last items. Positive feedbacks improve egos, but negative feedbacks improve businesses. It is quite important to have quite critical patients because they will help you manage and intervene the key aspects of your practice that may turn off your patients. Now, let's talk about something that is quite important as of now, marketing and positioning. Now, what is your brand? Do you only sell appointments or do you provide mental health care with empathy and scientific rigor? It's important that you clarify your value, put it on a slogan, and repeat it until it becomes part of your identity. It's important that when people, let's say patients, general public, or even other colleagues, other physicians, think about you because you can offer something specific that is of value to them. Be visible. In the digital age, silence is invisibility. Patients search, compare, and decide long before they meet you. If you are not present in blogs, social media, live talks, or community activities, someone else will be. Make sure it's your voice that guides them. Regarding this, nowadays it's pretty frequent in psychiatry or in mental health all around for patients with mental health needs to be exposed to TikToks, Instagram Reels, YouTube videos of people that have no knowledge or for specific formation in mental health. These so-called coaches that do not hold any kind of professional title or a licensing title that enables them to talk about mental health issues properly. And this is a terrain where we are losing because there will be always a good need of patient and public education regarding mental health topics. Make sure it's you, the one that is educating your community. It doesn't mean that you have to dance in TikTok or do things that are not aligned to your core values, but to share your experience and your views in this regard with your potential public. Now, one of the things that must be more carefully taken into account is reputation management. Please never ignore reputation. One positive review can bring 5 patients. One negative review, if ignored, can drive away 10 or even more. Reputation management is not vanity. It is survival in a world of digital transparency. And in this regard, that's the importance of giving an excellent user experience. Let the patients talk good things about your practice. Now, let's talk about efficiency and growth. The psychiatrist's time is not worth gold, it's worth platinum. If you spend more time on billing, compliance, or cleaning than on clinical work, you are losing value. You are wasting your talent. Learn to delegate. Hiring an assistant, it's not an expense. It is an investment in growth. You should know that in the beginning, and depending on the country where you are living, perhaps having an assistant can be easier or more difficult. For instance, here in Colombia, having an assistant, it's really difficult given the fiscal responsibilities that comes with a contract of a subordinate. But there will be one time where this is needed because you will be so busy attending patients that it will be almost impossible for you to manage the more administrative work or, for instance, to make the billing, to have the documents, the habilitating documentation, or the mandatory papers in order. You will need an assistant for this. And if given that you choose to become a manager, a business manager of a more complete or bigger establishment, you will need an assistant for managing the more manual work and giving you more leeway to do the true strategic management that will be very important in order to make your practice grow. Continuous improvement is not an option, it's a responsibility. Plan, do, check, and act. Repeat this cycle every quarter. It is the same principle we use in clinical research. Learn, adjust, and improve. This is how small practices grow into institutions. Make sure that if any kind of plan of improvement that you begin, it's successful, make sure to do it all the time. If your plan for improvement failed, well, reevaluate it. See why did it fail. It's really important. Many protocols, many plans will fail, and each failure will give you strength in learning and understanding. Okay. To close, let me remind you, good management is not about becoming less of a doctor. Please do not make that mistake. It is about becoming a better one. When we manage well, we free time, reduce stress, and expand our capacity to help our patients. And that's what truly matters. Thank you all for coming, and I hope you enjoyed my presentation. Have a good night.
Oh, it's really a thought-provoking presentation, and while checking the presentation, I or checking my daily activities, and I see that I need a much to improve, and I noted down the important areas to improvement. So I would say it's a thought-provoking presentation. So as Dr. Gaitan is not there, available to respond the queries, we can share our experiences or thoughts to the presentation, or to the private practice in psychiatry, and it is very common in low and middle income countries, especially in South Asia. So, if someone interested to share your voice and views, please feel free to do so.
Dr. Yasir, I believe most of us will require one person to hire an assistant.
And also the other management. So I never thought in such a manner. It's really a thought-provoking presentation.
Yeah, completely agree. Some good suggestions in the chat box. Maybe we can go to the next presentation, I believe.
I think the
Thank
final,
you so much.
the final word I would say, Juan Gaitan is very known for his very practical approaches, and I think I remember his talk about music therapy and dementia, and so I think what we can learn, it's his heart for problems, his detail for problems, and after having had so many stressful talks and very stressful events for patients and negative events, I think that managing something in a positive way is also a good message. So yeah, I would say, even so one can't listen to that, but I would say thank you for this talk.
Thank you, Shujit. So please go ahead with the next agenda. Thank you, Reina. Thank you, Shujit, for inviting me, giving me the opportunity to be here, and I enjoy the wonderful presentations, also the symposium.
Yeah, you're welcome coming back, when you have time.
Thank you so much. So now we are moving to the final presentation, and it's a totally different kind of presentation. I believe that this will be one of the great presentations we are going to have in this conference. This presentation is by Professor Dr. Parameswaran Ramakrishnan, and this will be chaired by Dr. Vipul Janardan. I request Dr. Vipul to introduce the speaker and invite the speaker for the final presentation. Over to you, Dr. Vipul.
Hello, everybody. So, though Dr. Parameswaran Ramakrishnan need not any introduction, he is a distinguished psychiatrist and chaplain, currently a child and adolescent psychiatrist fellow at Tower Health, Drexel University, Philadelphia, and a PhD candidate in theology, clinical chaplaincy, and the psychiatry at the. He has done psychiatry at the Graduate Theological Union, UC Berkeley. He is also medical director and the principal investigator of the Adi Bhatt Foundation in the New Delhi. His training spans Harvard Divinity School, Harvard Medical School, and the Stanford University. Dr. Ramakrishna's scholarly work explored the intersection of the psychiatry, spirituality, and the chaplaincy, with notable publication on awe mindfulness and the spiritual care in leading journal. His unique contribution lie in bridging contemporary tradition and the clinical psychiatry to development, transpersonal, and the holistic model of care. Over to you, Dr. Param.
Yeah. Thank you so much. I'm trying to bring my slide presentation. I am kind of struggling. Where is this? Okay, here it is. Okay, here. Thanks so much. Okay, this was my topic, evidence-based understanding. I know we don't have much time. It's very short. How does it go? What slide are you seeing, by the way? Are you seeing my first slide? Is my slide moving? Vipul, or?
We are seeing the first slide. The title slide is visible.
Okay, has it not moved down?
No, it's not moving.
How do I do that? Can anyone help me? Suggest me?
You can unshare it, and you can start resharing it again.
Oh, I see. Okay, so share it again. How about now?
Yeah, it is opening. Now it is visible. Yeah, now it is moving.
Okay, perfect. Okay. So I have a confessional statement. I could have titled this in different ways. One of the interesting ways I wanted to title it was Mind Theta Gamma. Is there a place for soul in psychiatry? Those who are old timers, I'm old timer, we know that there used to be called as phenomenological psychiatry. Probably it is there in various parts of the world, but definitely has died down in USA. If any one of you heard or practiced phenomenological approach or trained in it, you can raise your hand just to show to others. I would be happy to see any one hand going up. Okay, the word psychiatry means healer of the soul, ein mind. Okay, that was the original term psychiatry means, and it's a Greek term, and there are still old timers, or still many people who are trained in the spirituality and psychiatry or phenomenology. They say that psychiatrists need to be healers of the soul as well as of mind. So now, phenomenological psychiatry, it disappeared. We call the term used in published articles is it died. Okay, when DSM-3 came into existence, the reasons why phenomenological psychiatry died was because of these four reasons. It was a subjective experiential way of understanding our patients' thoughts and feelings and their concerns, worries, and all those things, which are their intra-psychic processes. A phenomenon is one which is when the signs and symptoms which we collect to codify it by DSM codes, those signs and symptoms are just presentations of the internal psychiatric processes, internal psychological processes happening in the head of the patient. Okay, so a psychiatrist is supposed to subjectively experience the thoughts, feelings, pain, struggles, everything that patients go through in their patient's own first-person experience. That is the idea that the possibility of that was the idea behind phenomenological psychiatry. Because it was a subjective way of interpreting what's patient's private stuff, people started criticizing it as it's impossible to have a subject, have an understanding of what's happening inside the heart and mind of another person. Okay, so that was one criticism why it got killed. The second one was, if it is subjective way of understanding, there cannot be a framework. How would you train your future generation of kids, psychiatry residents in such a process? So it has to be removed. Another major thing was understanding of the internal subjective thoughts and feelings comes through something what they call a metaphysical element in it. Metaphysical element is nothing but spiritual beyond physical elements, okay, or transcendental states. So you cannot objectify a transcendental stuff when we are actually going towards the direction of evidence-based development of the discipline of psychiatry. So those were the criticisms. Okay, so when I was going through my psychiatry residency in India, I started seeing that pills don't help the patients as much as they should, or as continuous as they should. Episodes, relapses keeps happening, number one. If we add another tool of psychotherapy to a pill, psychopharmacology, then of course it will benefit, but still it doesn't help. And I divided these two things as physical therapy, just like biopsychosocial spiritual model. So pills or physical, psychosocial or therapies, the psychotherapies or social work therapies, help, support, and all. And then the third element of spiritual care is never addressed. So I thought, let me do something. So I came to USA, took a flight, and accidentally in spiritual world, people say that there's nothing called accident. Everything is pre-planned, divinely organized. So I accidentally fell into this department called as clinical chaplaincy. It is a 100-year-long program in this country, in USA, and it has grown in a very big way to be very evidence-based, but still not so evidence-based. So when I joined this program, I was told, I know I've created an AI pictures of myself and my patients. Thank you for the AI presentation just a while ago. So I have pictured myself with a doctor's coat and steth, but I was told to be chaplain, not to tell anyone that I'm a doctor, because that's the requirement of being a chaplain. We are all called chaplains in the spiritual care department. It's an accredited 1-year-long accredited training program, and it's very rigorous, so rigorous that I would put a 1-year-long chaplaincy program on one side of a measuring scale, and that will be heavier than 3 years of training as a psychiatrist. Okay, so I'll tell you this, present this as a narrative story. Okay, narrative, not as a. I'll go to the biological evidence-based stuff in a while, in a minute. Okay, so I saw this patient, a 72-year-old guy with a status post left piece of the lung resected because of the lung cancer, because he was a heavy smoker. He was a microbiology professor. He was a doctor. Okay, and he was so sad. The reason for his sadness, I sat with him in the very ideal empathic listening care process that is supposed to be as a clinical spiritual care trainee, okay, resident. Okay, I did the best of the thing which I learned through 6 months of the training program. It took 6 months for me to train to become a very beautifully empathic listening spiritual care provider. Okay, so I sat with him for almost 1 hour. Okay, and somewhere in between, he started saying that he's sad because not only that he is dying because there's a resurrection, there's a relapse of his tumor, but also he has very big guilt that he killed his 40-year-old loving daughter who died of cancer because of secondhand smoke from him. She was never a smoker. She was never done anything. So that was his deepest pain. Okay. After he said that, and then he stopped. And then I continued with my empathic listening, and he broke down. Okay, and in between, he was so disturbed that he used to go back to watching the TV, which was playing a basketball game. Okay, and it was hard for me to redirect again. You cannot redirect. We had to bring him back in an empathic way. It's a very deep learning training process, which I cannot explain in a few minutes here. Okay, so at the end, I gave a prayer, and then I wrote my notes. I walked through the corridor, took my turn to the left to an elevator, and pressed the button there to go to the 5th floor to my sleep room, because on that day it was my night shift day as a chaplain, supervised spiritual care. So I pressed that button. I went into the sleep room. I was lying on the bed. When I pressed that button, another button got pressed in my head, and I kind of woke up from some kind of a trance-like state of mind. I'll come to this trance-like state of mind in a minute. But I went to my sleep room. I was lying in my bed, and I was thinking, all this clinical chaplaincy, spiritual care, empathic listening is all bullshit. Let me go tomorrow morning, visit the patient again, and provide the beautiful CPD. I am trained as a psychiatrist back in India. Okay, that's what I thought. And next day morning, I went to the patient. I saw him. He was already a changed man. The patient said that, thanks for coming yesterday. I woke up this morning with my feet 3 feet above the ground. Okay. Wow, I was surprised. I was shocked. I went with a different intention, right? I was shocked. And then I said thank you and all. I was stepping out of the room. There was a nephew sitting in the room with this patient. He told the nephew, "This chaplain is my real doctor." In that hospital, nobody knows that I was the doctor already. Okay, so that's what he said. Again, I prayed and got out. I was putting my notes, and the nurse came up and she said, "What did you do?" This is the fourth day of his admission in the hospital, and this is the first day he ate breakfast this morning. In the last 4 days, he has not eaten. Okay, I ran up to my professor in my department, and I asked him, "What happened?" This is the entire story. I told him. I said, "This is what happened, but I don't understand how he got healed." Nowhere in my psychiatry residency training or psychiatric practice, I practiced 10 years before I came to USA, I had such a kind of experience. Okay, the chaplain supervisor, spiritual care supervisor, he told me, "Param, you are not the healer in a spiritual care. God is a healer." Okay, I asked, I didn't understand how do I comprehend all this? How do I grapple with all this? I asked a couple other senior chaplains in the department. All had the same answer. So now I had a big question for myself. I came to spiritual care department to learn the tools so that I can take it back to psychiatry and develop an integrated spirituality psychiatry program. And now a big boulder is thrown right in front of me to try and understand God as a healer, but in an evidence-based way. How do I take that God as an evidence-based God back into my psychiatry? That was my big question. I'll stop here and ask you all my questions. Okay, my questions are, which God came to heal the patient? The patient was a Christian patient. I'm a Hindu chaplain. Which God came to heal the patient? Christian God or Hindu God? Or better, how do you understand God as a healer in this situation? Nobody saw any person called as God coming in picture. Number two, how do we develop this into evidence-based understanding of God? I'll pause here for maybe 2 minutes. Somebody can ping me, wake me up. I don't know what's the India time now. Maybe if you're all feeling sleepy, I will let you go with a dream to with these thoughts to dream about. Is there any questions, sir? Sujit, do you see anyone raising hand? Sujita?
There are some responses in the chat box.
Yeah, I can't see it. Okay, how do I see? I can't see it because my entire screen is.
I'm just going through the comments. One participant said that God is the energy. Another person said that the collective positive energy. The understanding about God is in the form of energy, maybe a collective positive energy.
Fine. Whoever has answered that, can you please think, how will you bring that energy, collective positive energy, into an evidence-based understanding to start teaching this methodology to our residents? You can speak. You don't put. I'm not able to see your chat box. Please speak. Please feel free to speak out.
Good evening, sir. I'm Deblina, and I would like to put it in this aspect that I don't know how to exactly measure the presence of God with the chaplain at a clinical setting, but maybe we can see the uh, we can measure maybe like that, in a way that there is positive sense of well-being when the conversation is happening, and we can take that moment as the presence of God, where this
Beautiful.
thing start changing.
Beautiful, beautiful. But whenever you answer, please question yourself, think about your own practice, and see how it's valid or you need to go deeper. For example, every patient in my clinical psychiatric practice, they were in love with me. They used to feel great about my presence, and everybody would say, "Wow, God, doctor." In India, they would say, "Oh, aap Bhagwan hai." They give a lot of gifts also, right? That that cannot translate. Sometimes you won't know, but that what they're saying is they're just trying to be nice to you because you have been nice doctor to them, or did they feel God come and felt touched by the God? How would you measure? Mine is a deeper question, my dear. I told you I had never had any such experience when I was a psychiatrist for 10 or more years. Okay, I'll stop here. Devlina, thank you so much. Okay, I appreciate. Is there anyone who wants to answer?
One way of looking into this issue is in many countries, including India, faith healing is quite common. People go to, may it be for medical illness, may it be for psychiatric illness, they go to the faith healers, to the traditional healers, to the temples, to the church, to the mosque. And many of these people, they report that there is improvement in their symptoms. What we use a antidepressant or any other medication to treat these conditions, they also use through their belief, their rituals, they also improve many of these things. So maybe something, a strong belief, a strong faith on something.
Okay, Sujita ji, got it. Thank you so much. But how will you convert it into an evidence-based medicine? You can't bring all those things into a psychiatry, right? That's the question. I will answer. I will give you the next sections. Okay. Thank you. This is brilliant. I wanted someone to talk. Not talking is bad. Talking anything is good. Okay. See this. What happened? Okay. I knew in chaplaincy we need to go deep into. Somebody is raising their hand. Is it a reason? Or is it my hand raising? Okay. Fine. So here is a thing. The clinical chaplaincy, clinical spiritual care is heavily informed by theology, one's own theology. Okay. So one of the theologies that I have, Hindu theology, is Aham Brahmasmi, right? God, the self is God. There is Brahman deep within us and the Brahman deep within the patient. I started wondering, is it possible how the Brahman deep within the patient, though even if it is Christian, he may not be having understanding of what Hindus talk about. But through my lens, if I see his own stuff, is there a possibility of the Brahman in me waking up to heal him, or the patient's own Brahman has woken up to heal him? In putting in a different sense, the Krishna, my religious Krishna, has healed him, or was I that good to wake up Jesus to come and heal him, because Jesus and Christian patient, they are belonging to the same religion? Okay, these are the deeper thinking. It looks very simple and childish, but deeper thinking. Okay, what I did was I went to okay, all through my drive back home from my hospital to India, to my home, I had to, it's a 1 hour long drive. I thought I had to cross this beautiful hill, mountain, the snow mountain in our place called as Mount Rainier. So I went home and I looked up to see if there are any such papers. And I immediately found a paper, some very short paper, a British guy, he wrote a paper on secrets and magic of empathic listening. So he also felt that I did not do anything, just like how I was feeling. I did not do anything for his healing. So he wrote, I don't know what I did. I did not do anything. But the patient said, doctor, you are a good listener, empathic listener. Okay. So that told me that there's something very secret. And the doctor writes in his paper, learn your own secrets in your magical empathic listening presence. Okay, so what I did was I put together everything that I saw as a case study. I published in the Indian Journal of Psychiatry, and this is still the first neuropsych based paper existing on spiritual care. Okay, I'm writing my own papers coming up soon, second and more deeper versions of it. Okay, and then what I did, I took my car literally, but and I went to Harvard. I got selected into Harvard Divinity School to study theology from all five different religious traditions, and I started writing theoretical frameworks. I was also getting afraid that I was moving far away from psychiatry. Okay, so I wrote to the chairman of psychiatry department at Harvard, and I said that I don't want to get lost. So he said, come and join my program on contemplative neuroscience research. So I joined his research project. In his research lab, I was developing contemplative neuroscience frameworks of inter-religious theology in a clinical chaplaincy. While at the Divinity School, I was writing frameworks on inter-religious theology, the same Atma, Brahman thing. Is it existing in other religious traditions, or is it only Hinduism? Guess what? Every religious tradition has that same kind of understanding of God as their own soul. Everybody has it. Okay, I'll come to that at some point. I don't think time will permit today, but I'll keep going. So this is one of the definitions of spirituality developed by Western scholars. Koenig, if anyone has heard Harold Koenig, you will know who he is. He is a professor of psychiatry at Duke University. I have highlighted the portion of the spirituality definition. The transcendent is one which is outside of oneself, yet also within oneself. And in Western traditions, it is called as God, Hashem, higher power, Allah, etc. In Eastern traditions, it is called as Brahman or Buddha, ultimate reality, and all. Does it strike a bell to any one of you? A Hindu scriptural tradition, scripture, Rig Veda, Ekam Sat Vipraha Bahuda Vadanti. You see how people bring Hindu scriptures into play with the modern tradition, but still we are not reached there to find an evidence-based understanding of any scripture, including Hinduism. Okay. So what I did was I wrote my theoretical frameworks. Okay, this is a framework of the interactive process between a chaplain and a patient. There's a figurative description, illustration. Okay, and I completed my master's thesis and published a paper, and then I went to, and then on the very last day, I was introduced to something called as portable EEG device. It's called as Muse. It was sold for consumers to practice and deepen their meditative practices. That's what's there on the left side is a Muse device. It's a portable device. You can just wear it on your head. You can go and talk to your patients. So I use this device to understand if the theoretical frameworks that I developed is true or false. Okay, and then I went to do PhD to improve my master's thesis into a PhD dissertation. My PhD was at UC Berkeley. Okay, while I improved my theoretical frameworks at UC Berkeley, after improving, okay, I went to Stanford. I'll cut short all these slides. I don't have time. Okay, I will tell you the circled areas, orange waves, which you can see right on top of the waves. They are they are the markers, gamma predominant spikes or plateaus, summits, which are markers of self-transcendent state of mind, which is actually the super Brahman state of mind or Father God state or Allah state of mind. Okay, if Yasser Arafat is there, if you're there, Yasser Arafat, a very interesting understanding of Allah. I'll just give it to you as a homework to dig into. How did the word Allah come into being as the name of the Supreme God? You can think over, and towards the end you can answer. Okay, I will go forward. Okay, so and gamma was the gamma predominant is a marker for self-transcendent state, the Allah state, or Bhagwan, Brahman, or Father God state, while a conjoint, twinning of the red and purple lines, waves, which are delta and theta, they are the markers for meditative, deep meditative, but not at transcendental state. Okay, that state is marked by twinning of delta and theta. Okay, and then what I did was I wore this device. I went to Stanford. I sat in front of patients wearing the device and started doing my empathic listening care. One of my very first patients, this is the, I have stories. Spirituality has to be subjective experiential understanding. To add to that, we need to bring in other evidences, okay? Hardcore evidences that I'm using. So this guy, this patient, he remarked as follows, okay? He said, family of, okay, very quickly the story. This story was a very interesting multi-religious family, okay? This from guess where? From Palestine, okay? Israel-Palestine area. A Jew, okay? He came to this country, USA. He got converted into Christianity. He continued to have a boyfriend who was a Jew. His nieces were Muslims, burqa. They were wearing burqa in the, and all of them were sitting in the room. And I provided spiritual care, and everybody had tears in their eyes. But the Jewish guy who had died, 75-year-old guy died, and his partner was still sitting there, and he was given a task by the guy with the dead guy for completing the will. The will is his body should be donated to a medical school for students to dissect and learn. After all the dissection process, his body should be cremated. And the partner had a tough choice how to get through this completing his will. Okay, I did not know. I was a fresh chaplain. I did not know how the process. So I said, I will talk to my supervisor. She may be knowing, and she would come and advise you. When my supervisor went to advise, at that point, that guy who did not cry, tears, goosebumps, and there are various other physiological and happiness, cheerfulness, conversion of facial expressions, affect. These are the indicators of healing. So I could see that others had healed because of their tears, vulnerable tears, but this guy did not. When my supervisor went, he broke down. Okay, and this is what he and others told my supervisor. Family of deceased patient on dash floor described Krish, they call me Krish, as dazzling. Never ever anyone I have heard, or myself as a psychiatrist, having received a feedback saying that you are dazzling. Never ever. He came in, sat down, listened. Here the word listened is empathic listening. As they talked about the patient, when he prayed, when the chaplain Krish prayed, he lifted up all those things that they said, and it was a very spiritual experience. Okay, mark the encircled words. Okay, these are the patient's experiences. Look at my experiences on the graph. This was my graph, right? I was wearing the graph. The patient was not wearing. Look at the graph. you will see how I've seen how I have encircled it. Okay. On the other side, what happened is, as soon as I heard my supervisor give that feedback to me, I ran back to see the patients, and patients had few more choice words to tell me, to explain how they felt. The Muslim lady who was in burqa, two people, mother and daughter, this is what they said: aha, mashallah, that was dazzling. That was very spiritual. It was so peaceful and calming. The guy, Jewish guy, we said, shalom, shalom, that is what it was. It was indeed healing. Yes, it was very dazzling. Okay, both of them, they pulled their sleeves and they showed me goosebumps. They still had when they were reflecting on it. Okay, these are all evidence-based, but still I'll tell you what else can be much more deeper evidence-based stuff. Okay, this is another different patient. Okay, similar thing. I don't have time, I guess, so I'll run through. Maybe for other reason, other time I will explain. The patient, in a follow-up visit, I was not sure what I did in the first visit. In a follow-up visit, this patient called me, "Hello, Jesus," because she did not know what my name is. She addressed me with the name Jesus. And when I asked why she did it, slowly I asked over a period of half an hour, she said she felt touched and in her heart and soul. Look at the gamma wave which has gone up. This is again still my EEG wave, okay? See how it ends up with gamma spikes. It means I had entered into self-transcendent state. Again, you will see that twinning of the theta delta before the gamma spike comes, okay? Okay, so here is another, and then what I did was, I wanted to see whether the patient, care recipient, also goes into a self-transcendent state for him or her to experience healing. So I developed a classroom-based case study where both the provider and the recipient both were wearing the EEG device, okay? And see what happens. On one side, the care provider, that's me, my EEG. On the other side was the other guy, okay? So that other guy was a Muslim, okay? He was a medical student, okay? Mashallah, aap mere nafs ko pakad liye. You were able to grasp my soul. You were able to feel and see all my deep thoughts. He was in this country from India. He was struggling through marriage, child, and also not getting into residency program. So that's what he was saying. I will pass the USMLE and I will get into the program. Okay, see my goosebumps. These are very common occurrences. Okay, so that's his email. That's his EEG. Okay, and now another patient, a Hindu patient, who was struggling through relationship issues. Okay, broken relationship. Okay, and that was my graph, EEG graph. See the spikes, and this was a medical student. The previous one was a medical grad, has come from India to USA. This was a medical student in this country. Okay, thank you. Wow, you helped me. You helped me see how my ex helped me see God in big ways. You're able to see the deep part of my soul. Okay, these are the words which, okay, that medical student's EEG graph. You see how there is a synchronization of mine and his gamma spikes. See towards the end, last three bubbles, circles on his subject's EEG, and compare with the minutes or the timings that were where the spikes came up in my EEG. Okay, and we had a comparative study of two groups: people receiving spiritual care from trained providers, me and another trained person, two providers, and another group where the spiritual care was offered by providers not trained in the CP, they're not trained in the empathic listening process. It's a specialized form of talking to a patient, specialized form of psychiatric assessment. It's not any, we are all who have come into medical school and become doctors, we are empathic in some way. But that empathy is different from what a real empathy has to be to produce this kind of effect. It's a big training process. We'll come to that at some point. Okay. So there are 6 and 6 case studies from both the groups. None of the group cases in the comparative group with no trained provider, none of them had gamma spikes except for 1 or 2 patients who became very tearful. The providers never had in all the 6 cases, and in all the 6 cases nobody had a synchronization. There's no synchronization between the EEG of the provider and the patient compared to the test group where both the providers were trained. Everyone went through gamma spikes, at least 1 spike, if not more than 1, and all provider patient comparative studies had the concurrent or coincidence or synchronization of the gamma spikes. Okay, so what we have come is we have used the subjective experiences, the provider's subjective experiences, and then the objective existing neuroscience framework. The objective existing neuroscience framework is gamma predominant spikes are markers for transcendental states of mind. For meditative states before pre-transcendence, mindful states, transcendence is a beyond mindfulness state. Mindful state is marked by theta delta. Okay, and non-mindful state, which is a typical state of a worried mind, is, you know what it is, gamma predominant state. Okay, so it's all there in the literature, and we found those things in our EEG graphs, the green circle. When we bring all these circles together, in the middle where all 4 overlap, that is the evidence-based spirituality or evidence-based psychiatric assessment. Okay, so if we are providing evidence-based care in current day psychiatry, if I ask you, you should be able to provide EEG evidence saying that you and your patients had entered a transcendental state of mind, which is impossible if we are sitting in front of the patient, listening to his story, but continuously running the DSM criteria in our head, trying to see where should I fit this patient. It's impossible to reach a transcendental state of mind. Okay, so let's go ahead what I did further. So I put these 4 things together, and I arrived at the definition of what is transcendence, definition of what is soul. Soul is a state of mind which is self-reflective state of mind. To understand how soul is self-reflective compared to a transcendental state of mind, which is a non-reflective but is beyond reflective state, we have to read theologies. Theologies of which theology? Every religious theology has it. It is there in Quran, it is there in Bible, it is there in Bhagavad Gita, of course, it's there in Buddhist text, it's there in Parkayavot, in Torah, in every scripture. If we don't know how to study, how to understand God or divine or spirit or soul in a clinical interaction, we can never ever understand it from a scriptural textbook. Okay, so what I'm trying to say is, just like you can never understand anything about the disease process of a patient if you just mug up and by heart all that thing in a Kaplan and Sadok without seeing any depression patient. You cannot understand it. Similarly, and to understand better what we read in a textbook, we go back and forth between the textbook and the patient, right? Similarly, to understand what is a soul, spirit, or God, we should go back and forth between a spiritual care interaction in a clinical setting and a scriptural text. We had to go and back and forth. This is called as medical model of reading scriptural text. And another third project, what I did was I took people, okay, and I read scriptures. I'm running through. I know I ran through scriptures, reading Ramayana, reading Quran and Hadith, reading Bible. Okay, I read all those things. We are coming up with all these papers on evidence-based study of what is scriptural text, and it is important for psychiatrists. So these are all going to be part of the curriculum. I'll stop here. Okay. Thank you. I'll ask. I'm ready for any questions. I'm short my timing. Okay, and I'll stop my thing here. Thank you so much for your patience.
Thank you so much, Dr. Ramakrishnan. I think Dr. Vipul Janardan is not here because he has to leave for another meeting. So I have to conclude here. Before concluding the sessions, I would like to have questions from the participants. Because this is something very sensitive topic, something that's a very inherent topic. There will be a lot of questions and there will be a lot of opinions. So I would like to have any comments or any questions from the participants. There are some comments in the chat box. Wonderful, inspiring talk, sir. Absolute fan of yours. And there are some comments.
Thank you, Deblina. Thank you, Dr. Deblina.
Maybe Dr. Rainer, would you like to comment or ask anything?
I don't know. I think I'm not an expert in spirituality because I always believe that so much what we do is not explainable anyway. So the question is, how does psychiatry work at all, or how does it, how does CBT work? The problem is what we always do is nobody understands what happens in the brain. What we show is that it works. And the why is always difficult. And this goes through whatever spirituality. It goes through the work of ketamine, and so there's so many things, and how CBT works. I think CBT has a little theory. I think we're possibly, and I think the interesting part is that we can move more and more into assessing these issues, and spirituality is one. So I don't know. And the other thing is, I would also connect it a little bit with AI. So how does it work that things, look as if, so it's even AI sometimes looks as the spirit comes out of the box. So I don't know. I don't want to be critical, but I think it's good that we have started these different types of questions. And if we don't have any further discussions, I would say I give the penultimate talk and say we had very, very interesting discussions. We had a great meeting. I always say we have members from or listeners from all the continents except Australia. Now we have one colleague who just listens from New Zealand. So I'm quite proud that we touched so many people and touched so many ears. And I'm very proud that we thank for Dr. Ramakrishnan for his contributions and his, let's say, different views. And I must say I'm very, very impressed by this chaplaincy approach to psychiatry. And I think, listening is a great skill of a psychiatrist. How does it work? I think it's amazing because that's what people really want when they go to a psychiatrist. And when you come up with all the medications and all the stuff, people say you haven't listened to me, which is the most important part. And I think, maybe we should have another workshop on this if Dr. Ramakrishnan can put something together. I would say thank you to everybody. So now I finish. Would say thank you to everybody. We have done a great symposium, and I think the biggest thank you goes to Professor Sujit Kar, who has managed this, and yeah, who should be proud of himself how this was organized. It will take me some time to get some of the talks up to our website, Global Psychiatry Archives, and I also would thank you people who are not psychiatrists and who have done a great job. And I wish we wouldn't only have chaplains and nurses within our team, but also OTs, psychologists, and everybody who works in mental health, and we can all learn from each other. And yeah, thank you so much, Sujit. It was amazing, and we're moving forward, and we can get some, I would say, workshops on AI, spirituality, sadly about war, and how we can make an impact, a positive impact as a Global Psychiatric Association to help people in war and suffering from mental health problems from war. That would be absolutely amazing. Thanks a lot. Thanks everybody around the world, and yeah, thanks so much, Sujit.
Thank you so much, everyone. Thank you so much. I think we can close the meeting here, and Professor Ramakrishnan will having a dedicated symposium on spirituality and mental health. If you agree to it, we can have it some down the
Let's
line.
do.
Yeah.
Let's do. Definitely, I'm in for it. Thank you, Sujit.
Thank you so much. Thank you.
Thank you.
Thank you. Thank you so much, everyone. Thank you so much, Professor Rainer. Now we can close the meeting.
Okay. Thanks, Sujit, Okay. Bye-bye.
Bye-bye.